This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 665, recorded on September 18th, 2020. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York State, Daniel Griffin.
Hello, everyone.
How's it going, Daniel?
You know, it's going well, actually. I think things are still, it's all relative, isn't it? I was just thinking as I was heading to my recording site for this, just about it's crazy to say things are going well when, over 200,000 Americans have died of COVID-19. And I was just thinking about, the Vietnam War, where 50-something thousand Americans lost their lives, and we're now looking at 4 times that number. And I'm saying like things are going well. Things are not going well.
No,
it's just. It is crazy to me that we are okay with what's going on right now, that somehow we're getting, this has become the new norm and somehow we've adjusted to it.
Well, I think not everyone has. Do you have patients in hospital now, COVID-19 patients?
I do. And I'm gonna specifically talk about them because I always like to keep the human side. So this isn't all just about the numbers. So yeah, let me hit right to that. So I'll do the, I'll do my quotation, which this might remind you of Dixon or not when you hear this. But yeah, let's talk. Give people a little bit of update on a couple patients that I've talked about, and some of our listeners say that hey, they like to hear updates, how they're doing. So the quotation this week is from the Dalai Lama. If you think you are too small to make a difference, try sleeping with a mosquito.
He really said that. That's amazing.
So I thought that was great.
Very good.
And I know Dixon, when he hears that, will enjoy that if he listens to the first part of TWiV when I talk. But yeah, let's start with an update. So right now I have a couple patients in the hospital with COVID-19. And one of them I've talked about for a while. This was one of my coworkers who got ill. She was actually admitted in mid-July. So it has been over 2 months. And this is a woman, actually, I was joking with her yesterday that she and I are actually not very different in age. And she, prior to this, was a healthy woman, no pre-existing medical problems. She ended up coming in early in the course of disease. So she got all the different things that we think are helpful. She got remdesivir. She got steroids. We even did the tocilizumab because she was continuing to get worse. We even did this second round of steroids. And I think I related to people that was when the D-dimer was at 13,000. Things were going in the wrong direction. And that was the next morning. She was eating her turkey sandwich. She was, again, relatively improved. She is still in the intensive care unit. It's 2 months in. She's still on a significant amount of oxygen. Darshan Patel, the ICU doc that I've been working with for actually a number of years now. He's a fellow sailor. I used to see him out on the bay. Now we're both working too much. He and I were talking and went ahead and did a repeat CAT scan of her chest. And it's heartbreaking. There's, large holes. I mean, holes you could put your thumb or a golf ball in her lungs as part of the COVID process. A lot of what should be airspace, it's just this gray. We know from some of the studies that that's inflammatory cells. It's this fibrinous material. And so we were talking, like, is this a woman who at some point needs to be considered for lung transplants? Because how are you ever going to work? We have her on 6 liters of oxygen when she's sitting there not moving. As soon as she exerts herself, she requires high flow oxygen, and it's 2 months. So this is really, just keeps reminding you that COVID has not gone away.
Daniel, does she continue to have an inflammatory response, or is this just after that? And this is the damage.
That's an interesting issue, and that's something we talked about. People that develop a pulmonary fibrosis, there's a syndrome called idiopathic pulmonary fibrosis, and those individuals actually get treated for long courses of steroids, and then they're put on antibiotics to protect them from the infections they might get. When you look at the inflammatory markers in this woman, ferritin, the ESR, the CRP, the D-dimer, which we now realize is a combination of part of the clotting and the inflammation system. These are all elevated. And so that was part of this discussion we had today. Like, do we do something like this here? And again, this gets us back to all these questions where we don't have great, control trials to guide us. How many women are like this colleague of mine, still having this tail end. And so, that's something that I think tomorrow we'll be talking about. Again, as we brought up today, let's see what the CAT scan looks like. And, this woman can't go home requiring this plus oxygen. So do we consider putting her on a low dose of steroids to see if that has any impact? I mean, these are these unknowns that we don't really know about.
Is she PCR negative at this point?
She's been PCR negative for over a month. Okay. The other woman that I described, this is a woman whose husband died. This is the woman who was at the wake. And she actually, the last couple of days, she had gotten better, right? She was down to just 2 liters of oxygen. We were starting to feel good and starting to think about discharge planning, but her oxygen requirement had gone up. Her neutrophils had gone up. We started her on empiric antibiotics yesterday, concerned that she was about the time in the course when people get bacterial infections. She had started having these chills, seemed to be like a Riger's type reaction. Actually, today when I saw her, she was saying that since the start of antibiotics, she feels better, no more of these shaking chills, and her neutrophil count had started to come down. The eosinophils had started to come back. So that's encouraging. She is still PCR positive, though. So she's still, she's about 3 weeks or so into this.
You don't know the CT, of course, right?
Yeah, I'm going to call up Tony Fauci because he claims he can get those for me. Just joking. So, yeah, we don't. I mean, I'd love to know that, right? I mean, it would at least give you something, that we could keep track of. I know it's not FDA approved, and a lot of the machines actually are these template mediated amplification where you really just at 40 cycles you say yes or no. So we don't really have access to the information. But all right, let me do some news. We had some interesting news. We had some more information on pregnancy and COVID-19. And I reached out to my buddy, Justin Aaron at Columbia to, he was worried because his wife had been pregnant. But about a month ago, she gave birth. So he's got a 1 month old, his second child. So congratulations to Justin Aaron. And also, his wife's no longer pregnant. So we don't have to worry about his wife, at least. But this was a study that actually was in the MMWR reports. So the morbidity and mortality weekly reports. And there was some interesting things. I didn't know this, but approximately 5% of all women of reproductive age in the general population in the United States are pregnant at any given time. Just didn't know that. Sort of an interesting. And this was a study looking at the proportion of hospitalized women in this age, so 15 to 49 in this reproductive age zone. And of the women that got admitted to the hospital, 26.5% of them were pregnant. So pregnant women are disproportionately higher rates of COVID-19. So as far as how did these women do? I mean, it looks like a disproportionate number of the women who are admitted are pregnant. So 26.5 versus only 5%. Among these hospitalized symptomatic pregnant women, 16% were admitted to the ICU, 8.5% required mechanical ventilation, but the deaths were less than 1%. This always reminds me of that CNN appearance where I'm live on the air, adjusting my bow tie, and I've been asked to come and speak about Trump and testing. And they say, "All right, Dan, so tell us about pregnant women and COVID." And it's the deer in the headlights. Where I was like, there's really no data. So as I think Anthony Fauci has made famous, we are in a data-free zone. CNN,
a data-free zone. Well, now you can call up CNN and say, "Now we have data. You want to talk about it?"
Exactly. I'll go back. Maybe actually. We've talked about this before, but I've got some positive news. And this is the use of monoclonal antibody therapy. And this is early on, right? These are people who are in the first week of disease. So Lilly announced this proof of concept data for their neutralizing antibody. It's very catchy, right? LYCOV 555. And they did this study. It's an outpatient setting study, and we've talked about this a little bit before. What is this for our listeners who, I know we say it's all doctors up front, but I know we've got a lot of non-doctors listening. So this is a monoclonal antibody. It's an IgG. There are 4 subclasses. This is subclass 1, so IgG1. And what do you think it targets, Vincent? I'm sure you know.
Spike glycoprotein.
Yes, of course. So yeah, it's actually directed against the spike protein. It was actually isolated from a patient. And I was looking for sort of the details. I'm sort of wanted to get a little bit more in the weeds on how they actually isolated and then got enough of this antibody to do their trials. But they really rapidly developed this. And in this study, they looked at 452 folks. 302 were in the treatment group because they were looking at different dosages. There were 150 in the placebo control part of it. And 1.7% of the patients that got the antibody ended up either hospitalized or needing to go to the ER, where 6% of the placebo patients. So this corresponds to a 72% risk reduction. But we always like to put this in absolute numbers. Really, it's 6 minus 1.7. So that's about a 4.3, reduction. So you got to give this to a lot of people. But it is really encouraging if you can identify those higher risk individuals and get them access to this treatment very early on. It's very promising.
How early on, Daniel? Was it in hospital they got this treatment?
No. So these folks, I know this has come up before. These were individuals, 3 who had a SARS-CoV-2 PCR test no more than 3 days prior to drug infusion. So these were targeting people in the first week. And this is the outpatient setting. Yep. So you don't need to be in the hospital to access this.
But you need to go to a healthcare facility because it's intravenously delivered, right?
You do. Okay. Or the healthcare people could come to you.
That's right.
So like if you're really special like you, Vincent, we could send them to your house.
Okay. I hope that doesn't happen.
Yeah. But no, I mean, I think you bring up the limitations of this therapy. This isn't just a pill. This isn't something you can have in a box at home and, get your test and then immediately just pop your monoclonal antibody cocktail. So,
well, if you can give this early enough, it will work, right? The problem is if you only give it to very sick people, like we saw with remdesivir, you don't have much of a good outcome, right?
Yeah. I mean, it is the timing, as suggested. We all thought this was going to be critical that this was given early, and it's great to see that it's being given when it should be given, and it's showing pretty significant. I mean, a 72% risk reduction, at least in this limited population that we've looked at so far. That's very encouraging. I mean, this is good news.
And you found this out somehow specially because there's no news about this out there yet, right?
Oh, I didn't know that. You can, I did not know I was so special. So, but I'm sure Eli Lilly will spread the word.
Okay.
Yeah, we can, hopefully we can actually find a link and we'll get in the show notes and then everyone can get.
I found links to the initiation of the phase 3, which was last month.
Okay.
And that's what you're talking about. This is a phase 3, correct?
Yeah, this was a, we'll call it a preliminary report And actually, they're going to expand this, so they're going to be looking at a larger number of individuals, and so we'll get more data, and also encouraging, right? I mean, it's nice to know that there's good news that we're making progress. Eli Lilly is not the only group working on the monoclonal antibody or the monoclonal antibody cocktails. We talked about Regeneron, and I know that our group has tried to work with them, and I think are working with them to try to get their stuff out there as well, urgent care centers, things like that. So, so we're making progress.
Good.
Now, I want to devote actually a lot of today. I always like to have a theme to what we're going to talk about, and this goes back to the quotation. How can we all make a difference? And so today I'm going to talk about behaviors. We've actually learned quite a bit about things that we as individuals, we as a society can do to either increase or hopefully decrease our risk of getting COVID-19. So number one, going out to a restaurant, bar or coffee shop. I'll keep you involved here, Vincent. Does that increase or decrease your risk?
That increases your risk for sure.
Yes. So again, people have been a little hard on the CDC, but I'm going to say, again, the CDC Morbidity and Mortality Weekly Report came out with some really nice information. And it was community and close contact exposures associated with COVID-19 among symptomatic adults, so folks greater than 18 years. They looked at 11 outpatient healthcare facilities in the United States. So this was a pretty nice snapshot of different behaviors associated with, what were people doing and did this impact your risk? I actually, people, not while you're driving, pull over, because we don't want to have deaths that way. But, this is worth looking through. It's very interesting. They've got really nice tables. You don't have to you have to be a reader. This could be like the comic book where you flip to the interesting pictures, but they look at a whole bunch of different activities. And they looked specifically at, these are people you didn't know how they got it. So how could they have got it unbeknownst to them? So without a known close contact with a person with confirmed 19. And when you looked at this compared the folks that got sick compared to the people that didn't get sick, the people that did get sick were more likely to report dining at a restaurant, and that had an adjusted odd ratio of 2.8. So almost 3 times as likely. A smaller number of people reported going to, and I found this funny, they lump bar and coffee shop together, right? To just, I think there's 2 different crowds. There's the crowd that goes to bars and there's a crowd that goes to coffee shops. And maybe there's a little judginess back and forth between the 2 groups. But whether it was a bar or a coffee shop, that was an adjusted odd ratio of 3.9. So almost 4. But I will say, this study didn't assess indoor versus outdoor dining options when they were looking at people going to restaurants, bars, or coffee shops.
Yeah.
And they also didn't give us as much of a breakdown. They didn't really have enough numbers to break this down. But I think there's people that would like to know, what is a coffee shop risk relative to a bar risk, relative to a restaurant, and then relative to an outdoor dining venue at a restaurant. But we're starting to get some information about, things, because people are starting to consider, will I go out to restaurants? Will I go to a restaurant that has indoor dining? And it would be nice to have a little bit more information about outdoor versus indoor. So that's number 2, indoor versus outdoor transmission.
Daniel,
So
if I were to guess, I would say bars would have the highest because the behavior there is very different from a coffee shop, which tends to be calmer.
I suspect you're right. A lot of times when I'm asked to give input on things, I give all the input and then I throw in the caveat. And then once the alcohol is served.
That's right. That's right.
Because, so indoor versus outdoor. So to go back a ways, because I want to give a little bit of the story here. So back in April, there was a preprint. It was actually posted by the Japanese Ministry of Health, Labor, and Welfare. And they spell labor O-U-R. So I'm not sure what that is. That must be the British/Japanese spelling translation. And this was, sort of striking. Closed environments facilitate secondary transmission of coronavirus disease 2019, right? So this is back when we were using the full name there. And basically what they came out in this study, and this is, I sort of quote this number as a ballpark, but saying that the odds that a primary case transmitted COVID-19 in a closed environment was 18.7 times greater compared to an open air environment. So really sort of gave us this first. And then the same group actually published again, CDC Journal, Emerging Infectious Disease Clusters of Coronavirus Disease in Communities in Japan. And they actually, again, were sort of reinforcing this, saying, and I'm going to quote, we noted many COVID-19 clusters were associated with heavy breathing in close proximity, such as singing at karaoke parties, right? We know we're in Japan, cheering at clubs, having conversations in bars, and exercising in gymnasiums. I cringe at the last one there. And they come up with this, they call it the 3 C's, and they recommend avoiding the 3 C's, closed spaces with poor ventilation, crowded places, and close contact settings. Mm-hmm. I cringe at the last part because I went to the gym this week. It was my first time, and I almost felt like I was going as a scientist. I went to the gym. You sign up ahead of time. You fill this health declaration form out. But it was funny because I had the person at reception, and he's like, "Oh yeah, so you go here. Okay, now you just scroll to the bottom." And I was like, "Shouldn't I be reading?" No, you just scroll to the bottom. You check this box, and then click. Oh, now you're good. Now you can go in. I was like, so I'm sure that's actually how it's done. I'm sure people don't read through, oh, wait, actually it says here, I do have that symptom. Let me click no, so I can't go to the gym. And I wore a mask the entire time. I know people complain about masks, but I ran on the treadmill with a mask. I guess I've been training to do that. And there were only 3 other people in the entire gym. So I don't know. It's interesting. As we try to figure out how to move forward with what, is a marathon, not a sprint. Maybe that's a good, parallel here or good analogy. The next, and this was when I read the title to this next paper, my wife laughed, and it's wearing glasses is associated with reduced COVID-19. So association of daily wear of eyeglasses with susceptibility to coronavirus disease 2019 infection. And this was in JAMA Ophthalmology. And my wife just laughed. She's like, really? Being nearsighted protects you? So as I suggested, it's not being nearsighted. I think that what the suggestion here, and so this was a study in this area in China, in Hubei, and it was, they basically looked around, they said, you know what, and I think this is where it came from, we're noticing that though a large percentage of people, about 1/3 of the people in this region wear glasses, we're only seeing about 1 in 20 patients who get hospitalized wear glasses. And so the general sort of background, 31.5% of the population reported myopia and wearing glasses on a regular basis, but less than 6% of the individuals hospitalized with COVID-19 wore glasses. So very interesting. I'm sure this will get a bit of news attention, but we're having the JCO, the Joint Commission, come visit and look at our hospitals and our behavior. And as I've talked about for, I think, a few times on TWiV, is that part of protecting yourself from droplet exposure is protecting your mouth, protecting your nose, and protecting your eyes. So those of you watching this on YouTube, Vincent will survive the pandemic. I won't. But no, I do. I actually wear goggles when I'm in the room with a patient, when I'm within that 6 feet. And I think that...
it could be, Daniel, the glasses, or it could be that people who wear glasses do something else that put them at lower risk.
I think, isn't it the people that wear glasses are smarter? So, Vincent, you can let us know. With our N of 2, I'm going to say that I think that might be it. But I think this will be interesting to look at because we've, I remember so many months ago, we were trying to go through the mask data. And there was not a lot, and we're going to jump into that. But I think that it would be nice to have more data just letting us know if you wear protective eyewear, what's the impact? How much protection do you get there? Yeah. And I think to seg into masks, you did that well. We now have hundreds of studies of various quality that give us an estimate of masks reducing transmission by somewhere between 50 and 75%. So that's actually a pretty good number. And I think that's an interesting number because this week the CDC director, Dr. Robert Redfield, told the Senate Appropriations Subcommittee that wearing face masks might really be something that could eventually make a big difference. He had some sort of number. If we wore them consistently for a matter of weeks, we could really see the future much better than it is. And then he made an interesting point in there. That's why I go to this 50 to 75. They might work even better than an eventual vaccine might. And I sort of thought about that. That's interesting. I guess it's simple math, right? We're saying that the vaccines to be put out there need to be 50% or more effective. And if masks are really 50 to 75% effective, then, masks might actually, provide more protection than the low bar vaccine that gets out there. And I think this is interesting. I'm still sort of shocked, I'm going to say, that we have such an anti-mask movement in America. And, we have an anti-vaccine movement as well. And, I talked to my dad, who's like, I am just going to stay super safe and super careful until we have a vaccine. And this sort of made me think about it. So what if that vaccine is 52% protective, Dad? Is that okay? I mean, by a vaccine, I think people are thinking a vaccine where they can then get a test and know that, oh, I am protected. But it's probably going to take multiple measures. It's going to take vaccines. It's going to take masks. It's going to take all these different things working together. Contact precautions, all this deep cleaning. And so I was spending a lot of time. You'll see the gist here of looking at CDC sources. And they basically were saying, listen, here we are. It's September 2020. COVID-19 is primarily transmitted from person to person through respiratory droplets. Current evidence, and we now have a lot of it, suggests that surface contact transmission or fomite transmission is a possible route of infection, but only appears to account for a minority of the transmission events. So this reinforces for, I think, those of us clinicians who are making recommendations to patients that a significant risk is when you are within 6 feet of an infected person for more than 15 minutes without a mask, particularly if this occurs indoors, and while that other person is either breathing, talking, or coughing. We just had a recent cluster here that I got involved with where the school gym teacher, who was also the baseball coach, just tested positive for COVID-19. So we were going through, was he wearing a mask? Was he trying to, be outside? Was he, riding in the car with the players, et cetera? So we could do this calculation. And, in that situation where you're indoors and you're not wearing a mask and the other person is COVID-19, the risk is much higher. So my little commentary here, particularly when I see these 18-page school opening plans and 17 of the pages are about how we're going to wipe down the floors like every 2 hours. I feel there's an incredible amount of attention, hygiene theater, and a lot of expense that goes into this display of deep cleaning. And I think in a lot of ways, I worry that this effort distracts from efforts that really make a difference, such as wearing masks, now maybe eye protection, the physical distancing, and I'm going to say most importantly, testing.
Now, of course, those 17-page plans don't have any testing in them. That's the problem.
No, because they ran out of paper. So, all right, that's how you want to just, again, I want to thank everyone. Everyone's actually been really quite generous in going to parasiteswithoutborders.com and donating to help us support floating doctors. So please continue to do that. And if you're not going to parasiteswithoutborders.com, go to Microbe TV, right?
Yep, please do. All right, Daniel, I've got 3 questions for you.
Okay.
First one is from Lainey, who is a physician assistant in Knoxville, Tennessee, primarily serving individuals with HIV. A few TWiVs ago, someone commented that Dr. Griffin has not acquired a SARS-CoV-2 infection is remarkable. Now, I presume that part of his good fortune has to do with his judicious use of PPE, just as another panelist remarked. So here's my question. How concerned should healthcare professionals be about exposures at work, provided we have adequate supplies of PPE and are donning and doffing appropriately? I probably do not need to ask this, but are there any reliable data to support the answer you provide. I'm fortunate that my office quickly transitioned to doing a lot of appointments via telehealth, but as the pandemic continues to evolve, I've been seeing more and more patients in the office. I feel reasonably safe since they're all masked. I'm wearing appropriate PPE. Our office has instituted deep cleaning, disinfecting, social distancing, etc. But I'm interested in hearing your opinion on this matter.
Okay. Yes. Let me do that one first. And actually, I do think that you can feel confident, and there is significant amount of data behind this. If you look at when healthcare workers were acquiring SARS-CoV-2, when they were getting COVID-19, it was before there was, I'll say, appropriate and adequate personal protective equipment, supplies, and use. And if you look at, and a lot of facilities have published on this, once they instituted that and you had universal appropriate PPE wearing, you really saw minimal exposure to minimal infections in the healthcare workers. We had a personal experience, right? So early on, I was part of the North American Hydroxychloroquine Consortium, and I was a PI on a couple studies. And one of them was where healthcare workers were taking hydroxychloroquine, every day for months, and we were looking at exposures. But the funny thing is that was a lot of physicians here in the New York area, particularly at Pro Healthcare in New York. But I was also in charge of infection control and the chief of ID. So part of the problem we had with that study was 0 participants actually got SARS-CoV-2, whether they were placebo or not. And so our actual infection rate, 1,000 plus providers, was lower than the community average. So interesting enough, and this is why I feel bad for the teachers, right? I told the story about the security guard who was working in the morgue, all the proper personal protective equipment. He made it through, and then it's when he went back to the school and didn't have a mask and didn't have the appropriate protection. And that's when he got COVID-19 and ended up, almost intubated 3 times and actually quite ill. So I think there is good evidence and a lot of studies showing that once you implement it and you follow your PPE protocols, donning and doffing appropriately, that it can actually be a low risk to be taking care of patients.
Elaine also wants to know, she applied for a vaccine trial, but was rejected because she's breastfeeding. And she asks if any of the vaccines will be approved for breastfeeding moms.
Wow, that's a great question. Because, this is I think we just talked about 5% of women in that, 15 to 49, the reproductive age zone, are pregnant at any given time. So are we going to exclude them? Are we going to say, oh no, 5% of women and they just can't, and then pregnancy lasts, 9.5 months. But then people breastfeed maybe 6 months. They might breastfeed out to 3 years, actually. We're sort of hippie parents, I guess. We did about 3 years. By we, I mean my wife. I was,
You were supportive, right?
It was harder on me. No, it certainly wasn't. But no, I think that in the early part of the trials, I understand that there's a lot of exclusion. And as we've been going through working with some of the people with how they're going to fill their trials, initially you start off with a limited number, but then you expand because you really don't want to exclude pregnant women from the ability to get vaccinated. But I think this is just a phenomenon of where we are with the rolling out of the trials.
What's the reason for excluding breastfeeding women from the trial?
So, it depends on which vaccine you use. So I'll talk a little bit. If you use, for instance, an attenuated viral vaccine,
Sure.
The concern would be a transmission.
Sure.
If you're using, an mRNA or a DNA, theoretically would be, again, the transmission through the breast milk of this vaccine. I don't think we're particularly worried, in all honesty, about antibodies. I mean, that's ultimately going to be the idea, is that you vaccinate the mom and the antibodies are going to provide a passive immunity for the child. But again, I'll say with COVID-19, a lot of the pathology is related to the antibodies, right? I think there was a paper that came out, and I thought it was funny. I was on a call with one of the people at United Health Group, where we're in this big thousands of people serology kinetic study we're trying to work on, where I was saying early on, we noticed that the sickest people had the highest antibody levels. And there was recently this publication where they sort of basically just worded it backwards. The people like highest antibody levels associated with, worse disease. There is some concern, the transverse myelitis, the MS, the other, that could antibodies cross to the child and have some deleterious effect.
Got it.
I think until we get a better lay of the land, there's a lot of different reasons why this might be the case.
All right. Jason has a nice story about wanting to have his TWiV gear blessed for Rosh Hashanah. I will leave the listeners to read that in the show notes. It's really nice.
Okay, I could do the El Shana Tova. Your stuff is now blessed over the airwaves.
All right.
Just hold it under your screen there. The New Year is coming up this weekend.
That's right. Question for Dr. Griffin. I know you've discussed the issue with false positives in a place with relatively low prevalence of COVID-19, such as New York. Last week, there was a question from someone who wanted to visit an elderly father after the person's mother passed. Dr. Griffin spoke about the possibility of getting a rapid test right before the visit. Would you speak about any danger there would be about a false negative on the test? Is that less of a concern in a place like New York where there's currently a relatively low prevalence? I presume you are recommending a test that would return very quick results, and the visit should happen in a period of time as close to the test as possible. Is there any evidence on the interval of time from a person being infected to the person showing up as PCR positive?
Yeah, so there's several aspects to this email. It's actually very well written, sort of breaking them down. People have, I think, this concept, different tests and what are their sensitivities and which ones are better. And as I think we've tried to repeatedly talk about, there's tests that we use as clinicians for diagnostic tests to determine is what we're seeing related to COVID-19. And so the diagnostic test versus a public health type test, which is a test that's very good at picking up people who are infectious. And I think now months of data that people are infectious when they have 1 million or more RNA copy numbers per milliliter. And all, our tests across the board, all the ones that we're currently using are very good, well into the 90s for sensitivity there. So particularly when you have a family that comes in, say, we're about to go to visit, I think we mentioned that the father had lost his wife. If you test the son, the wife, the kids, and everyone's negative, you have a pretty high degree of confidence in the very upper 90s. Nothing's 100%. I'll definitely admit that. But you can feel pretty good about that. And whether it's an Abbott ID Now or whether it's the BD rapid strip or whether it's one of these PCR or TMA type of PCR tests, these are all actually going to be very, very good at picking up someone who's right at that point in time, positive, infectious, able to make someone sick. But let's talk a little bit about the kinetics. So when you get exposed, when do you start shedding virus? And that, I think people forget about this. So I'm glad this email was written. And that was, I was walking on the beach the other day and I ran into one of the girls who was on a soccer team. I coached soccer for about a decade. And she was relating the story how she was out at Madison and they've got a bit of an outbreak there. I think it's like 10% positive. And so this girl got tested, was negative, immediately jumped on a plane, and now she's back in New York. So when she told me the story, I backed from 6 to 8 feet, get that extra 2 feet. Because from the time you get exposed to the time you get sick, that's really a window of 2 to 14 days. And so at any point during that period of time, and we think particularly in young individuals, as many as half of them can be shedding virus, spreading virus, but not have any symptoms. So, there's really this period of time from 2 to 14 days when you can start shedding virus. We think the amount of virus goes up pretty rapidly. I like to use the image of the slide at the playground, somewhere about 2 to 3 days prior to symptoms. If you'll have symptoms, the PCR rises pretty quickly. Not like you're going to get a negative test in the morning and be positive by lunch or anything. But it's going to go up, then it's going to actually be higher, probably right before symptom onset, and then it's going to come down. So that window from the 2 to 3 4 until out is somewhere between a 7 to 12 days. But we think most of the infections from some of the recent study are occurring in that real 5 days, so from 2 days to 5. But think about that. From the time you get exposed out to 14 days, you could start shedding virus. And if you get sick at day 14, you could then be shedding virus past there.
Sure.
So I think this is really important. A negative test immediately after an exposure does not suddenly vanish away the incubation period.
Yeah. So there's a risk with the person visiting his father at the funeral, even if tested. In other words,
yeah, you really want to have that test very close to the time and that's the advantage of the rapids.
Yeah.
If you do, let's say, I did the PCR because I felt it was more sensitive, but it takes you 2 days to get the result. That's a test from 2 days ago.
Yeah.
A rapid right now, I actually feel is a better, more reliable, safer approach than a lower viral load sensitivity assay whose results you don't get for days.
So Jason says, please, listeners, support TWiV. Thank you, Jason. You can go to microbe.tv/contribute. And our last one's from Tony. Thanks to Dr. Griffin for weekly updates and episode 663, the rundown on vaccine trials. Many people like that, Daniel. Am I correct to assume that if someone enrolls in a trial, that person would be prevented from getting a different vaccine, let's say one that's been approved while the person's trial is ongoing? 1, to preserve the validity of trial participation, and 2, because of possible negative interactions between the vaccines. Could taking one vaccine possibly make a different one ineffective? Is this something a person should consider before participating in a trial?
I guess I'm going to stop saying every email is great, because they really are. I mean, I read these emails and I'm like, this is excellent. I think I could probably talk about COVID-19 and vaccines all day. And so there's a couple really interesting issues here. And so the first one, right, is that we have these vaccines out there. And so let's say Moderna has, they're going to have 30,000 people, and Pfizer's going to have 30,000 people in their mRNA ones. And then AstraZeneca is going to have 30,000 people in their ChAdOx one. And then each of these different vaccines are going to have their group of individuals in the study. And so let's say you're in a study and it's who knows how long, 6 months in. Because theoretically with vaccines, we follow people for a year, 2 years. We follow for a long time. It turns out one of the vaccines, the news flash comes on, Moderna vaccine, is 90% effective. And, there's going to be a real drive for people to say, I want to just sort of drop out of this vaccine study and jump and get that vaccine. And this is something a lot of us are really quite worried about, because we need the science. And if you have people who are in one vaccine trial and then they basically renege, and you can, I mean, that's what that's the whole part of research protection in the United States. At any point, for any reason, you can step back and leave a research study. You can say, I no longer want to be involved. I just want to go my own way. So people can do that. There's no way to actually prevent them. The only way to prevent them is education and encouraging them. And I think if you're going to be in a vaccine trial, don't think of this as, this is my way to access the vaccine early. This is really your chance to make a difference. I mean, you'll be able to look back and say, you know what? I was one of the people that helped bring these vaccines to the public. I was one of the people that helped end the pandemic. When I was in medical school, I volunteered. I was one of the original recipients of hepatitis A vaccine, hepatitis B vaccine. So, people now know how old I am. That was well into the last century when those were being developed. And I felt like, there were two motivations. One was I didn't have a lot of money and it was a paid gig. But the other was, and I think that I'm going to encourage people here, is that this is really a chance to be part of history. You can look back and say, you know what? I signed up. I was one of the first people to get vaccinated, or not. I could have been in the placebo arm. It doesn't matter. But I was one of the people that helped end this pandemic. And the vaccine is going to be part of that. Now, the second part, what if you just, what if you decide, yeah, that's great and all, Dr. Griffin, but I really want that vaccine that works. What about negative interactions? And there's two issues here. One is we don't know. And we've talked about the antibodies can potentially cause harm. And so if you get one vaccine and then you get another, does that create some sort of a different response that isn't being studied? Well, one, it's not being studied. And part of it is something that we refer to in immunology as the butterfly effect. And maybe people remember the Ray Bradbury book, but once you do one thing, it affects the future. And once you have an antibody response against the spike protein, for instance, that's going to shape all your subsequent immune responses. So if you get one vaccine and then you get a second vaccine, your response to that second vaccine is going to be different because of that first vaccine. And we're not going to be able to study that. Yeah. So I would say that, one is kudos to everyone who's being part of ending this pandemic by being part of the vaccine trials, but make the commitment, because we don't know if it will be safe to just jump ship and take some other vaccine.
This is really an unprecedented situation where we have so many different vaccines for the same infectious agent, right? Usually there's one or two.
Yeah, no, it's really true, right? Certain diseases, we have a couple, right? Like we have the old shingles and then the new shingles vaccine. So that's sort of an easy. For meningococcal disease, so meningitis, we have a couple different, but that's usually what you're dealing with, a couple different options. HPV, right? We have a couple different vaccines to help protect individuals against the cervical cancer, so cervical cancer vaccine options, but not like, 200, and, a bunch already in phase 3 trials. So no, this is clearly unprecedented.
All right, that's our weekly COVID-19 update with Dr. Daniel Griffin. Thanks so much again, Daniel. Appreciate it.
All right. Thank you so much, everyone. Have a good week.
Joining me today from Madison, New Jersey, Brienne Barker.
Hi, it's great to be here. It is currently 68 Fahrenheit and actually sunny. We haven't seen much sun this week.
Yeah, the sun's out. And it is 20 C, which is the same as your temperature.
Yeah, it's kind of nice. Starting to feel like fall.
Indeed.
From Austin, Texas, Rich Condit.
Hi, everybody. We've got 85 and partly cloudy, which by itself is a break. The high tomorrow is supposed to be 79.
Not
and
bad.
The day after that, 72. Rain in the forecast. I'm loving it.
Sounds good. Maybe I'll have to send you a hoodie.
From Fort Lee, New Jersey, Dixon Despommier.
Hello there, Vincent. Brienne's weather is out my window, so I guess all three of us have the same situation. It's very pleasant. No frost on the pumpkin here, but in Michigan, frost on the pumpkin. Wow, that's a sign of the times.
And from Western Massachusetts, Alan Dove.
Good to be here. It's 58 Fahrenheit overcast. That's 14 Celsius. And we are going to have frost on the pumpkins here tonight. There's a frost advisory.
Wow.
So light frost, bring in your last of your tomato plants or what have you.
Yeah. Nice.
Man, that's incredible. When you live in the South, you just forget about this. I go pack up to go someplace in the fall, and I pack my shorts and my T-shirts, I forget that it gets cold places.
True. That's going to change too, though, Rich.
Yeah, it'll get cold here.
Another 50 years from now, it'll all be warm.
That's right. We're all being I'll be pushing daisies.
We'll be shaking hands. How's that?
Yeah, that's it.
I want to take this moment to publicly apologize to Dixon Despommier for my verbal abuse of him a few episodes. I guess it was a week ago, 663. It was inappropriate. A number of listeners have pointed it out. My colleagues have pointed it out and have asked it to cease, and it will. I also want to say that I recognize that I would never talk to a student that way, so I shouldn't. And we're all students, so I shouldn't talk to you or anyone else that way. So, Dixon, I hope you accept my apology and assurances that it will not happen again.
Of course I do. You're a good friend, and I would definitely miss you if something like this came between us. So thank you for your apology.
You're welcome. Thank you all for bringing it up, those of you who have written, my colleagues here. And it's an important part of the show for us to be collegial.
Indeed.
A few things here before we start. First of all, of course, if you like what we do, you can consider supporting us financially. Go to microbe.tv/contribute. If you would like to chat with a virologist, you can go to asv.org and scroll down to where you see chat with a virologist. Apparently, there are rotating images You have to click on the side of those to get to it, and it's something they're trying to fix. It may be fixed by now. If you want to learn more about virology, you could take my online course, which is at virology.blog/course. And I would like to announce the availability of a technician position with Amy Rosenfeld to work on a SARS-CoV-2 project. We've recently got some funding for that, and it's very exciting. Applicants should have a Bachelor of Science in Science with some lab experience. And Amy asked me to say, not just a laboratory course, actual lab experience. You can email tech@microbe.tv if you're interested. In fact, a couple of years ago, we did the same, and our technician came through the ad in TWiV. It was Audrey. So we're hoping to have good luck again. All
Awesome.
right.
I will send that to lots of former students.
Yeah.
Guess what? I get to be a chat with the virologist. And
Yay!
this is a special one because the person who is involved with the Friends of the Library group in Buda invited me to do a Zoom chat with people there. And what I really like, I got to read this to you, is her suggested title is inspiring. What a virologist would like you to know.
Wow.
Okay, which is a great focus because I've thought about that a lot.
Absolutely.
What is it that I want people to understand? Not only about viruses, but also in this case about the disease. So that's going to be a fun challenge.
Oh,
That
great.
should be a blast.
That sounds great.
Gee, sorry we can't all be on it. But I would be out because I know I'm not a virologist, but you said I was, so I will take that.
Well, they can just listen to TWiV to hear all of
They
this.
can do that. They can do that.
And Rich, I mean, he's a local, so
That's fabulous, though, Rich.
Yeah, it's,
Congratulations.
Congratulations. Buda
we're
was
big
part
in
of my
Buda.
life. Who knew?
Yeah, yeah.
All right. We have two papers for you today before we get to some email. And these have both actually been published.
In peer-reviewed journals.
Yeah, they're not
Right.
just preprints. I shouldn't say just. They're not preprints because, but sometimes they change
I
between.
think just as appropriate for preprints.
You think?
They're work in progress. We do need to put an asterisk on those.
Yeah, so these now have been checked over by several reviewers. And I always, reviewers are meant to make sure that the conclusions are justified by the experiments, right?
Right.
And for some reviewers to make sure that their work has been properly cited, right?
Yes.
And as
Yeah.
as Ian Lipkin has told me, the function of a reviewer is to make sure that their competitor's work is delayed, which of course is not nice, but that's what Ian says. There are many quotes. There are many memorable quotes. Once a Nobel laureate said to me, "Vinny, it's best to be first and wrong than to be second."
Oh,
Is that terrible? This is not something
it's terrible.
we propagate here on TWiV. We'd like you to be correct. So the first of our peer-reviewed publications is published in Nature Medicine. It is a letter clustering and super spreading potential of SARS-CoV-2 infections in Hong Kong.
And this is open access. And just in case people weren't aware, a letter to Nature is not just like a letter to the editor. It's an actual scientific paper.
It's a paper.
It's just
yeah.
shorter than some of the longer ones that they have.
The authors are Dylan Adam, Wu Wang, Lao Sang, Koshimez, Leung, and Cowling from the University of Hong Kong, as you might guess, for a study about Hong Kong, and also University of New South Wales and the Institut Pasteur, which actually has institutes all over the world, but this one is in Paris. Super spreaders. A super spreader is someone who transmits an infection to more than the average transmitter would spread to. Okay. And they're well known for other infectious diseases. In my mind, the most famous super spreader was the doctor who treated some of the first SARS patients in Guangzhou in 2002. He then traveled to Hong Kong, stayed at the Metropole Hotel, and he died the next day. He got sick and he died the next day. But in the short time he was in the hotel, he infected 10 other people who flew to 10 different countries and brought the virus with them.
I got another famous historic super spreader.
Yep.
Typhoid Mary.
Typhoid Mary.
Yeah.
That's just who I was thinking of.
Yeah, me too. Me too. In fact, she spent some time at PNS.
Right. Yeah. And on an island off Manhattan, right? Wasn't she? She was confined on Hoffman or Swinburne Island. There was a quarantine there.
Right.
It's important to note, because we're going to be talking about this as individuals who infect a larger number of people. These are not generally people who are bad. Okay, this is and particularly in the case of SARS-CoV-2 and in the example for SARS-1 that Vincent just gave, these are people who generally have no idea that they are super spreaders. SARS-CoV-2, we've got the added complication that asymptomatic individuals or pre-symptomatic individuals can be highly contagious. And so it's a combination of having the disease and maybe a little bit about your biology, depending on the particular pathogen. I mean, Typhoid Mary was a carrier of typhoid fever, and there are such people who, for various reasons, are capable of being that when other people aren't. And she remained that way her whole life, by the way. But in the case of SARS-CoV-2, it could just be a timing issue. Like they're at that phase of the infection where they're really infectious. And if they'd just been staying home, then nobody would have gotten infected. But instead they happen to be bartenders or they happen to be musicians. And so for whatever reason, they find themselves in situations where this happens. So it's really, I think a lot of people in public health are moving to the term super spreader event rather than super spreader individuals. But this paper kind of encompasses both.
Yeah, so that's exactly what I sort of wanted to say. And I think that it's really important to remember that it may be more about the circumstance than the person in particular.
Yes.
Maybe it's more that Typhoid Mary was a cook.
Yes.
And handling food.
Yeah, it certainly had a major impact on her scope.
But I think there's potential for something about an individual to contribute to super spreading. And I'm thinking of if you are producing more virus than normal, there could be enough in the smallest droplets, the aerosols, to travel far and infect a lot of people as compared to normal. But it's never been shown.
You can imagine, I don't know necessarily with this virus, but with others, people who are immunosuppressed for whatever reason might have higher viral loads.
Yes. Now, I want to contrast it to, I'm sure people have heard of individuals who purposely infect others with HIV-1, right?
Right.
So they have sexual relations with many people, knowing they're infected because they have a vendetta. They're mad.
That's evil.
That's evil. Yes. So they're intentionally. I guess that's a super spreader event in the sense that they're spreading it to a lot of people, but it's because it's a
malicious super spreader event.
Absolutely. Absolutely.
And there's some infectious diseases where you are chronically infected and you have the potential to infect others for long periods of time. And of course, infections like SARS-CoV-2 are acute. They have a defined period. So it's a different situation. All right. So this, as we've said, these super spreader events happen with other infectious diseases. It's been suspected to occur with SARS-CoV-2, but I think this is the first detailed study which says, let's look at all the documented infections and can we see super spreading events?
And we do have clear documentation on specific super spreading events with SARS-CoV-2, like the Biogen meeting in Boston, like the choir practice in Washington or Oregon.
Yes.
These have become world famous events.
But how general is it, right?
How general is it, right?
Yes.
Okay, so that made headlines, but how many people are really getting infected this way? This study really does the hard work of tracking it all down.
Now, I feel that the next big study will come out of Sturgis.
There are yeah, there are some data coming from that, although the tracking is poor because they're
right.
scattered to 50 states. And of course, in this country, we're doing a very patchwork job of managing
Yep.
all of that.
Maybe we can get Geico to help us.
Right. But Hong Kong has, they're a densely populated island that handled this very well. They've got a lot of testing. They've got a very good health system. And so it was a good setting to do this type of study.
Yeah, one thing I'll also say about this paper is that if you read through it, both looking at the data and sort of just the way things are described, this is a really nice example of kind of what epidemiology is.
Yes.
And so if you were trying to understand what an epidemiologist would do, what kind of data they would use, what kind of math they would do, it's really nicely sort of displayed here.
I got a real Jon Snow vibe reading it.
Yeah.
That's right.
I remember I was like, wait, this is that one textbook I have, or this one textbook chapter I have my students read. It's exactly this.
Yeah.
The other thing I would like, I would like to just jump in here just for a moment and say, when I was a student in high school, somebody showed us a video, not a video, of course, it was a movie of a room that was filled with mouse traps that were set with little ping pong balls in them. And they were all in a room that was enclosed. It was like a squash court. And someone opened the door and threw in a single ping pong ball. And the next thing you know, the entire room just jumped off it just exploded. And you can imagine then that's a good visual for people who don't understand what it means when one person has it and gives it to 5 others. Those 5 people then give it to 5 others. And the next thing you know, you've got half of the world's population infected. And that's basically where we find ourselves.
I remember that same demonstration being used to demonstrate what a chain reaction is like.
Yeah, exactly right.
That is
An
that's
atomic
classic,
bomb.
That's
classic
why it was
application
used. That's why it was used.
Yeah.
So then I thought about photomultiplier effect, when you've got 1, then 10, then multiples of that, and those are log phase growths. And I'm not sure where this one falls into.
Well, the thing about super spreader events is that with some infectious diseases, you see much more individual spread. And so one person gives it to 3 people, and those 3 people give it to 3 people, and those 3 people give it to 3. And that's very effective. Obviously, a lot of diseases spread that way.
Sure.
With SARS-CoV-2, at least before this paper, it was isolated reports, and there was a suspicion that it might be more super spready. Is kind of this concept that's been thrown around, that it may be more that it may tend more toward these events where one person gives it to 2 people and they give it to 2 people, and then one of those 2 people goes to a party and gives it to 300 people, and then they each give it to 2 people, and so that may be. And so this paper, which we are eventually going to talk about the paper itself, is looking at that across Hong Kong. Like, how many of these cases came from super spreader events? How many of them were the smaller within household type of things?
So Hong Kong did pretty well, I would say.
Yes.
As of the end of August, 4,700 laboratory confirmed cases.
That's incredible. What's the population of Hong Kong? Got to be like 15 or 20 million, right?
It's huge.
It is big. Very big.
I think it's millions and millions, yes.
Yes.
And the first case was on the 23rd of January. They had an increase. They did ban on entry, non-resident entry, 14-day quarantine for all resident arrivals, physical distancing measures. Cases went down, they relaxed, and they went back up again. So it just goes to show. Don't relax, yeah. So they, for this particular study, they have 1,038 cases in Hong Kong up to 28th of April. Over half of them, 51%, were associated with at least one of 137 clusters. So a cluster is 2 or more cases. And the smallest cluster, well, the median size was 2, and the largest was 106 cases in one cluster. And you'll hear more about that.
That's 2 cases. 2 cases that are related to each other, right?
Yes.
In other words, somebody gave it to somebody else.
Right.
Right. So that's all done, but contact tracing, they figure out who got it from whom, right?
Quick footnote here, population in 2019 of Hong Kong was 7.5 million.
Okay.
The critical thing about it is that's 6,777 people per square kilometer, which is among the most densely populated places on Earth.
Mm-hmm. So a little more information on these clusters. about 40% of them these clusters. There were 220 clusters. Sorry, 1,000. How many clusters were there in all? I can't remember. 533
cases and
533 clusters. So about 40% of them were in 22 clusters initiated by a local case, whereas 89 cases belong to 29 clusters initiated by an imported case. So a lot of imported cases. And as you'll see later, they actually get rid of those in their final calculations because they can't actually be sure of the chain of infections. 63% of the clusters were overseas acquired.
Yeah, I was a little bit confused at the beginning when they said that the median size of the cluster was 2, because that meant that there were a fair number of clusters smaller than 2, which don't count as clusters.
Clusters, right?
And I think
I am a cluster of 1.
Yes. I think that most of those were probably cases that were acquired abroad. And those numbers look quite different when they take those out later.
Quite a few clusters, they could not identify onward local transmission. And then they had 500 cases could not be linked to any other case. And 90% of those came from outside of the country. So here we have a case positive. We don't know, 90% of the time they came from overseas, and then it's not connected to anything else. So it's quite a bit in Hong Kong. It's just reflective of how much international travel there is there.
Yeah. Yeah. In addition to being one of the most densely populated places on the planet, they are one of the busiest travel hubs.
And I've never been there. I bet Dixon's been
either.
there. And Rich.
No.
Nobody here, huh?
I haven't even transferred
You
flights there.
that's
haven't said
interesting.
No,
anything.
it used to be when you went there, though, you flew right down the middle of the city in order to land. And that was a little bit frightening, I think. You could see buildings on both sides of the airplane.
Well, where else were they going to put the airport?
Not a good thing. Well, they did eventually. They put it out into the middle of the ocean.
It's on an island now. Yeah.
And it's on
its
a
own.
fake island. That's right. So why do you think China wants this for their own? I mean, I think with all these COVID-19
it's a
cases.
big money.
No.
Big money. The reason it's such a huge travel point. I mean,
I
it's
understand.
like it's
actually
the center of commerce and has been for centuries.
Yeah.
So clearly we need to have a TWiV episode there
Yes.
so that we can all go once we
That's
can
right.
travel again.
Post-pandemic, we definitely need an invitation to Hong Kong.
You heard Tony, he said last week, probably by the end of 2021, things will be normal, assuming we have good vaccines.
Yeah.
Assuming we have good
vaccines.
And maybe
Although
a few drugs thrown in for good luck.
I think we've got enough shots on goal happening now with the 9 companies that are setting up or in phase 3 and the 100 plus more that are trying to. And I think we're going to get there.
Spike better be enough to do the job.
Spike better be. We're all betting on Spike.
We hope you're right. Interesting number of all the cases confirmed in Hong Kong, 18% were asymptomatic at confirmation. That's
18.
a lot. And that number
that's pretty consistent with what we're seeing, like 20 to 30% asymptomatic rate seems normal.
So asymptomatic infections do.
They say asymptomatic at confirmation.
Confirmation.
Right.
It could be that some of those are pre-symptomatic, right?
Yes.
Yes, of course.
But still.
What they don't say. All right. So then the largest cluster, which we mentioned already, 106 cases, was traced to 4 bars across Hong Kong.
I just love this.
But the original source could not be determined. They call this bar and band cluster because apparently musicians traveling among the bars were the ones who spread it.
And that gets back to that notion of super spreaders as people who just are in a situation. I mean, you think about the singer on stage and they feel great and they don't know they have the virus and they're spraying it out across the crowd.
Exactly right. That's right.
And so they consider this one SSE super spreader event number 1. This accounted for 10% of all cases in Hong Kong during the study period.
Wow.
And in fact, that's one of their final messages. These kinds of social venues, bars, and as you will see, weddings, temples. You'll see a monk who became a super spreader because they interact with a lot of people. These are the kinds of events, more than household events that
Yeah.
control most of the transmission, right?
Yeah, and I just noticed this. Different perspective on this. So we're not going to show it, but I can describe it. There's a figure in the paper, figure 2, that's a sort of a stick diagram
Yes.
of how these things happen, with dots representing individuals who were infected and lines connecting the transmission. And this bar is a cluster of these dots. And they also have them colored differently depending on whether the transmission was social or whether it was in the family or whether or not it was a local source of transmission. And in this bar band cluster, I just realized that in the core of this is all social transmission. Yes. And on the rim, on the outside, is all family transmission.
Yeah.
So when it gets to the families,
their kids.
Yeah, but then it burns out.
Yes.
Yep.
Okay.
Because Hong Kong, having had SARS experience, took things seriously, shut everything down. And I think what we're watching is the effect of that shutdown when they realized SARS-CoV-2 was spreading the community. Okay, everything's closed, including the bars. Now everybody's gone home and they're in their tiny Hong Kong apartments with their family. And so you've got these family infections going on, but it's not spreading anywhere because everything's closed.
Yeah, it's really interesting to see this. It's ringed, the social thing ringed with the family infection.
Yes.
Yeah, I was really struck by this figure as well, because one part of the figure shows, so they have parts that show the big bar cluster. They have 2 other kind of larger clusters, and then they have a piece that shows kind of the small clusters that have a couple people or something like that. And almost all of those small clusters are green, which are the family transmission. And you can see the big difference between the family transmissions having kind of smaller chains compared to the social.
And the smaller ones, the little ones in that figure, the vast majority of them have a black dot in the center, which represents imported source.
Yeah.
So it's all these cases coming in, and they're spreading within families almost exclusively. And that's where the virus is coming from.
The whole figure looks kind of like a fireworks display.
Yes, it does. Yes.
So that was then. This is now. As soon as the case rate goes down below a certain level, do they open back up again and expect the same thing to happen? Because that's exactly what's happening in Europe.
That's exactly what's happening in the U.S. when in states that are reopening stuff.
What about Hong Kong? What's their situation now?
I don't know what the current situation is in Hong Kong. They've been pretty stringent, and I know they're pretty on top of testing.
They say here that at the time of writing, these measures have been maintained.
Right.
Right.
So distancing and so forth are still in place in Hong Kong. And I suppose...
this really underscores the types of settings that people were wondering, well, gee, when can we reopen this? When can we reopen that? And people are not picking it up at the grocery store. When you want to reopen the music venues, actually, my wife and I have had tickets to a concert in Boston. Right. We got them right before the pandemic. And there was supposed to be this concert in April in Boston, group called The Onward. And we, obviously it got postponed. And then the postponement date came up, and they've postponed it again to a date that I also think won't happen. Yep. And those are just going to be they're going to have to be the last thing to reopen.
You see, I know there's an analogy here between what's going on now and horror movies. When you see a horror movie and the monster that's coming to get you suddenly disappears, and everybody relaxes, and the entire audience says, "Don't go in that room! Don't go in that room!" but everybody knows that they're going to go in the room because it's a horror movie. So when you say don't go out on that beach again, or don't go out in those bars again, nobody listens. They're not thinking of it as a monster. They're thinking of it as something that will never happen again, but it does.
Yep.
I would love to say, this is a monster virus. This is a monster that's just hiding behind the tree behind you.
That's a good analogy.
Really, because otherwise, how are you going to scare people into doing the right thing?
Yeah.
I mean, there's a whole group now that's protesting masks.
Of course.
What? Well, even the Centers for Disease Control says it's a good idea now. Not to bring politics into this, sorry.
Right.
But
So,
I mean, still, it's sad. Is Hong Kong a good complier in terms of distancing and masks in general?
Yeah,
I mean,
they point out in this that they have, with all of their orders, they have like 98% compliance.
98%. That's admirable.
Well,
That's
it is a small, densely populated, very cohesive place, and there's I think there's a sense of, okay, we're going to hunker down together as Hong Kong and take care of this. And I suspect that's a huge factor in controlling it.
Second largest cluster, 22 cases linked to 2 super spreader events at a wedding and a preceding social event. Again, a bunch of people together, right?
Rehearsal dinner or something. Yeah.
Third largest cluster was linked to exposure at a temple.
The monk.
And a monk who worked there, he reported no symptoms before confirmation, was probably the source of some or all of the 11 temple cases. So a monk is often among other people, right? And in this case, he or she didn't feel sick and was shedding virus. So asymptomatically infected people can transmit. And then they had these overseas acquired cluster cases, but they decided to exclude those from the analyses we'll tell you about right now, because they had uncertainties about the chains of transmission, overseas in particular. So what they did then is to calculate reproductive number, not the R naught, but the R, right? The R naught is the fundamental property of the virus, but this is after intervention, and the dispersion coefficient, which tells you how many infections are spread by what fraction of the population. And they do it twice. Once they use the data, and the second time they use a model because they feel they didn't have enough data for it, and they get similar numbers. In the end, the reproductive number is 0.62, less than 1, which is really where you want to get it, right? Remember, we had a letter last year from Germany where they said that one of the first goals was an R of 0.75. Mm-hmm. And lower, they had lower and lower ones, but they decided to pick that one because it would preserve the economy. And then the dispersion index was 0.33. And what that means is 17 to 19% of infections were responsible for 80% of all transmission events in Hong Kong, and 69% of cases did not infect anyone. That is amazing, right? Because I think a lot of people have this idea that everyone who's infected is transmitting it, but it's not the case. 69%
and this is
don't.
This roughly 20% doing 80% of the spread. That is a proportion or a rough proportion that comes up in all kinds of things. It's got a name. It's the Pareto principle, named after, I think, an Italian economist who initially observed that in many economies, 20% of the population controls 80% of the wealth. And this shows up in a whole bunch of phenomena in nature that 20% of the causes are responsible for 80% of the effects.
And we have talked about another study before from Adam Kucharski, which came up with a similar number independently. And they point out here that, here we had moderate levels of physical distancing. If we didn't have that, there would even be more super spreader events.
Yeah.
Right. And that's an important point.
Or the super spreader events would be even bigger.
Would be bigger.
So the people who are in the 80%, were they not well enough to go out and therefore they weren't involved in spreading?
Or
whereas
they
the 20% didn't even know they had it.
They're people, they're just in situations, or they're in situations at the time that they're most contagious that they don't have an opportunity to spread it.
Yeah.
They're whatever their situation was, either because of the way they felt or because of their viral titers or because of their job situation or whatever,
right.
It didn't get out.
So nursing homes have symptomatic spreaders.
Yes.
But But outside, in ordinary circumstances, the tendency is to think of the asymptomatics as the spreaders, and I'm not sure how that falls out here.
Nursing homes are that squash court full of mousetraps with the
Exactly right. Exactly.
So while you guys have been yakking, I've been looking up to see what the story is broadly in Hong Kong.
Yeah.
And I found a site that has an epi curve, and the curve that we're looking at in this paper bottoms out at the end of April, and they were okay until about the beginning of July, and then they had another peak that went up. It looks like the whole thing is maybe twice as big, almost.
How many cases a day, Rich?
Up to 150 cases a day.
Wow.
Okay. And it lasted from the beginning of July until it's bottoming out now. They basically brought it down by the beginning of September. So I don't know the whole story about that, right. But here's a country that has it under control. But if you're not constantly vigilant,
exactly,
right, it's going to blow up on you.
And we see this elsewhere too. New Zealand.
Yes.
Yep. Right.
Yes.
Did
Austin,
a great
Texas.
Job, and
Austin,
Texas.
Right. So countries like Spain and Italy are really getting hit hard right now.
Yeah, there's another resurgence in Europe right now.
So basically, social settings are the sites of these super spreader events. So they say suppression measures should focus on eliminating risk of super spreading by reducing the numbers of contacts in these social settings, right? And they say you could do this by closing venues, by reduced capacity, physical distancing, mask usage, but you have to hit these social settings that result in most of the transmission, and that makes a lot of sense.
Yeah, but
which is sad, and I mean bordering on tragic that we've got to shut down these gathering places and these social venues that people go to, and that's what's killing people.
Exactly.
It's just that's awful.
So in this regard, I had the opportunity last night to participate in a discussion that included the director of public health in Austin, talking about monitoring the spread in particular with the schools opening up.
Yeah.
And the worst situation that, they're seeing some increases amongst the age groups that go to school. Okay. They can't really, the way it's being done, they can't really narrow it down much more than that. It's the high schoolers that are the biggest issue. Okay. At least the high school age children are the biggest issue. And if I recall correctly, what he said was, from what they know, the spreading that's happening is not in the classrooms, but in the social interaction that's associated with going to school.
That's right.
Yeah.
And that makes sense, because the classrooms, people in whatever fashion are doing their best to enforce reasonable behaviors that we know are mitigating, masks and distancing in the classrooms. But you get outside of class and, you can't necessarily enforce them the same way.
And the tragedy of that is that one of the big arguments for resuming in-person school in any way with whatever measures is the social benefits that it brings to kids.
That's right.
And the social benefits it brings to kids are what's spreading the virus. And so it's just one of these.
Catch-22? Did you say
we're hosed? I mean, you can't do this right.
Right. These data sort of make you think, well, the obvious solution is to reduce the social interactions. But we certainly understand that causes its own set of problems.
Yeah, we are a social species.
Yes.
There were
it's hitting us where it hurts.
There was a program last night on NPR, a radio, that had a person who was tracking resurgence of COVID-19 in small rural universities, like Dartmouth, Reed, Oberlin, all these other small schools. And in fact, it's much less in those schools because those people are actually socially isolated from the rest of the world, and they stay in that bubble. And once they're tested and negative, He said you get very low levels of increase in those particular, but you have University of Illinois, University of Michigan, and places like that where it's impossible to stop the traffic of kids going in and out and taking planes and rides and stuff.
Well, in those rural schools,
Can't do it.
somebody's going to go home for the weekend eventually. And bring the virus back, and once it gets into that bubble,
that's true.
then it's going to spread just fine.
I've been watching the situation at Texas State where my daughter is on the faculty, and they're doing a job of monitoring. Okay, they have a certain number of cases. What they say, their evaluation of the situation at this point in time is that they're not getting spread within the university. The cases they're seeing are imported. It's early in the semester, but that's what they're seeing.
So, Brienne, how many people at Drew actually live on campus all year?
Usually we have quite a few. Since our classes are virtual and students had to sort of apply and get permission, I think that right now we're at under 10% capacity.
Under 10%, but under normal capacity, what percentage of the students are actually on campus?
I'll say 80.
80.
Yes, we do have a decent commuter population.
Right.
And so that's sort of the thing that I've always looked at with these models is how they're actually thinking about the differences between schools, just like you all were saying in terms of, the commuters, because that's clearly different between us and, say, Dartmouth.
Right. And they have Ben & Jerry's anyway, so.
Right.
So just two more things from this paper. One is very interesting. They make this case that if you're going to confirm and isolate cases, you have to do it quickly. For example, in Hong Kong, the median time from symptom to onset to confirmation was 4 days for local cluster cases and 6 days for infectors, the people who transmit it. By that time, any onward transmission has already occurred. So, confirmation and tracing, you have to do it really quickly. You can't waste time. Otherwise, the transmission has already occurred.
Yeah.
And it's useless.
This reminds me
the cows are out of the barn by then.
This reminds me of when my daughter got tested and the doctor told her, look, I've just tested you. I want you to isolate. Okay. You go home and you isolate. He said, I can't tell you how frustrating it is to call people up with their results and find out that they're out at a bar someplace.
Yeah. Yeah, well, sometime not too long ago, it was taking 2 weeks to get the test result, and in that time, you've transmitted it, right?
Yeah,
you have to do it quickly.
Did you get any idea of how much it costs your daughter to get that test?
It was free.
Excellent.
And I don't know where that money's coming from, but she got it at a local Doc in the Box, and they sent it off to Houston to a lab at I think it's at Baylor. Got the result back within 24 hours.
Nasal swab or spit?
That was a nasopharyngeal swab and a RT-PCR.
Good.
That was a while ago, but no forms, no questions, nothing. Just take the test. It's free.
That's as it should be.
There's a testing center up in New York State, just over the border, at the Anthony Wayne. It was a pull-off. It used to be a recreational area with swimming pools and everything else. It's a gigantic parking lot. And New York State has set up a testing facility, and I go fishing up by that way. And every time I pass that place, it says COVID testing, and just make your appointment and then show up. I went there last week, and it says no appointment necessary. Just drive in, get your test, and go. And the no appointment is absolutely key for this. And I don't know if it's free or not. I think it was free, actually.
One other interesting bit of information. They say 14% of these infections were sporadic local cases where there was neither a traceable contact with another case or a history of travel. They don't know where it came from. And they say, This is really cool, this untraceable fraction could be interpreted as an upper bound on the proportion of transmission arising from anonymous interactions, fomites, and or aerosols. So that's interesting because we don't know how much is coming from those. And this might be it where you can't trace anything.
I think that's, I really like that too. That's a great, first of all, a great conceptual leap from the paper.
Yes.
Okay. I like that. Okay. And second, a number that I can at least have there to refer to.
And as they point out, it's an upper bound. Like that's
Yeah.
the maximum percentage that could be transmitted through these more nebulous routes that we don't know about, because we've accounted for the other, 86.9% or, of cases.
Yep.
With the caveat that this is a context where they're already have a lot of mitigation procedures in place.
Yes.
So,
and they phrase it correctly right in the next paragraph where they say, we should note this relies on contact tracing data.
Yeah.
And so any issues with the contact tracing data could bias their results. And so some fraction of that 14% might be because somebody didn't admit to going to the bar.
Yeah.
So
or they forgot that they went someplace to socialize.
So in the end, what do you do? So we know now from this paper that the super spreader events are where a lot of people are together, social events. So they say rapid tracing and quarantine of confirmed contacts and physical distancing, closures, reduced capacity measures at high-risk social settings, bars, weddings, religious sites, restaurants, and that will prevent the super spreader events, and that gets rid of 80% of transmission, right? That would make a big impact.
I don't know if this came up on last episode or not, but there was also the CDC data that just came out last week where they looked at a bunch of cases and they concluded that one of the biggest risk factors was eating in a restaurant. Like their cases were much more likely to have dined indoors in a restaurant than their non-cases.
Yes.
It's also a good way to get a foodborne illness, right?
Well, okay, but we've been eating a lot of takeout lately, and you can get it that way too.
I don't want to, come down too hard on restaurants. I know a lot of people
they're wonderful.
Love them, and many people make a living, and that's fine. But there are some hazards.
And you can get foodborne illnesses at home too.
That's right.
You can. Yes, support your restaurants with takeout.
Yes.
But don't eat the mints when you go out.
Don't eat the mints.
Don't eat the mints, even if they're wrapped in plastic. Don't eat the mints.
And skip the sprouts.
And just today, it was announced that the governor of Texas has lightened up on the restrictions locally. Restaurants are going from 50 to 75% capacity. Actually, restaurants, retail office buildings, manufacturing, gyms, libraries, and museums. Bars remain closed.
Really?
Still got to wear masks. We'll see how all that goes.
How's that enforced?
With a gun, it's Texas.
All right. One more paper. This now in our continuing brand new Friday tradition, we're trying to get away from SARS-CoV-2. And this is not SARS-CoV-2, although it has implications for it.
It's still a coronavirus.
But I think even in the pre-COVID era, we would have done this paper because it's quite interesting.
Yeah.
Nature Communications article, Cryo-Em structure of coronavirus, HKU1, hemagglutinin-esterase, reveals architectural changes arising from prolonged circulation in humans. So bunch of institutions in the Netherlands, Herdus, Drudeit, Lang, Chamorkina, Pronker, Van Koepenveld, Snyder, and de Groot. Probably de Groot, I don't know. Anyway, HKU1.
We need Kathy's help.
I think that's de Groot.
De Groot.
I think it's de Groot.
This is about 2 of the 4 common cold coronas, which we've talked about quite a bit because we think they inform us about SARS-CoV-2, because after all, the human coronaviruses are spillovers from animal coronaviruses. And only these 5 now, 4 human common cold coronas have become human viruses. Now SARS-CoV-2, as they say, seems well on course to become established in humans. Yes. And they've all breached the barrier from non-human animals to humans. So if we can understand how they did that, can understand SARS-CoV-2 in future events as well. And so HKU1, and then there's a related human common cold corona, OC43. These are the beta coronavirus genus. and there's a subgenus Embeccovirus. And again, these cause common colds in immunocompetent individuals, but here they say in the frail, they can cause morbidity and mortality in the frail.
Yes.
Right? Probably.
And if you're writing historical fiction, HKU1 seems to have crossed over, spilled over into humans several centuries ago. We don't know from what animal or where, because it's
unknown
in here and nobody kept track of it. And OC43 came in somewhere between, they say, 70 to 120 years ago.
From a cow.
Apparently from cows.
From a bovine
Yeah, we
corona.
talked a little bit about that last time, and we were talking about hypotheses of what it could have looked like,
right?
And whether they could have looked like the SARS-CoV-2 epidemic when they spilled over. So I was actually kind of interested to read these references at some point.
So
OC43 is from when the cows came home, and we don't know when HKU1.
Yeah, Daniel calls it Old Cow 43 because of that.
Old Cow 43, that's good.
Ooh, I like that.
It's how he remembers it. So these are a bit different from SARS-CoV-2. They have an additional protein in the viral membrane. In addition to the spike, they have a protein called the hemagglutinin-esterase, which SARS-CoV-2 does not have. And these viruses do have a spike, and the spike binds the receptor. And in these cases, the receptor is a sialic acid. It happens to be 9-O-acetyl sialic acid. But they have a hemagglutinin-esterase. And this you need, if you are binding sialic acid, you need a esterase, which cleaves ester bonds in order to allow the viruses to move away from the cell when they're released. Otherwise, they'll just bind to sialic acid again and stick there. Same thing with hemagglutinins of influenza viruses, right? They bind sialic acid, and the viruses have a neuraminidase, an esterase, to cleave sialic acid off of the protein so that the viruses can move away.
Right, otherwise it would just be stuck to the cell that it
be stuck to the cell surface.
And one of our big drugs that we use to combat influenza blocks that neuraminidase. And so understanding this can give you some ideas about stopping these viral infections.
And sialic acid, by the way, is just you can think of it as a decoration that gets attached to proteins on the cell surface. It's a little chain sticking out, and it's put on a bunch of different proteins. So it's on the surfaces of all kinds of cells.
And it's usually the last sugar moiety on a chain of sugars.
Right.
And then a number of viruses will bind sialic acid, like influenza viruses, and here these two human common cold coronaviruses. So they have this, that's the focus of this paper, this hemagglutinin-esterase protein. And it's interesting because OC43 and HKU1 have lost a part of the function of this hemagglutinin-esterase. So that they still have the esterase function, which is to cleave sialic acid off, but they don't bind lectins anymore. They postulate that this has been lost from ancestral, and there are other viruses and animals that do have this lectin domain, and they think that it has been lost in evolution in the human respiratory tract. So the lectin function is lost. So in other words, they will still, in order for these esterases to work, they have to bind the sialic acid. So the neuraminidase of flu binds sialic acid, has a pocket. But in this case, the affinity has been reduced. Exactly why, I'm not sure, but it still will bind sialic acid, but at a marketed lower affinity because this lectin binding domain is gone. So anyway, they wanted to look at that for this HKU1 virus. It had already been done for OC43, that is the structure, the crystal structure of the hemagglutinin-esterase, but they couldn't get it to work for HKU1. So they decided to try cryo-electron microscopy, and it worked. And typically you use that for big proteins or virus particles, and it happened to work for this one because it's rather large. And they were able to produce the protein in cells, just the HE protein, and get the Cryo-Em structure, and that's what's reported in this paper. And what's very interesting is that the HE protein of HKU1, the core domain, is very similar to other HE proteins from animal coronaviruses. It's got the core, which has the esterase activity. But the the regions, the loops surrounding it have been reduced in size. So if you look at the two other examples they show, you have these protein loops sticking out from the core, but HKU1, they're gone. The loops are gone. They've been reduced by what they say are a number of deletions. And they feel that these deletions have accumulated over time as HKU1 circulated in humans. And those deletions remove the lectin or reduce the lectin binding activity of the hemagglutinin-esterase, right? And that's really the main message, right? The core of the protein is conserved. It has esterase activity, which allows it to cleave sialic acid, but it no longer has high affinity binding for lectins, and it still binds because it needs to bind sialic acid, but it doesn't bind with high affinity because it's lost these external loops. And
Actually, I have a clarification here because I was confused about the definition of lectin. And what I'm digging up here is that lectin actually is the protein that binds a carbohydrate.
Yeah, so the lectin domain has been reduced, right?
Right. And so is this, and I was confused about this. Does this mean that this thing will no longer bind sialic acid?
No, it will, but with reduced affinity, because if it doesn't bind, it's never going to cleave it.
Well, I figured maybe the receptor itself would bind the sialic acid. If this thing were in proximity, it could do it or something like that. But we're just talking about reduced affinity for its substrate.
My interpretation is it's reduced. I mean, they're kind of cagey about that. You know, they said it alters the dynamics of the interaction. I'm assuming it's reduced because I don't think it's good enough just for spike to bind, you know, and get it nearby.
Right. And the question that Rich is getting at really is the reduction in affinity, does it bind? Not can it bind? Like in an actual infection. So you've reduced the affinity of it. Maybe now it doesn't bind. Maybe now you do need the other.
So I have not. Yeah, I misstated. The lectin domain is of the HE, which binds other sugars besides sialic acid. So the idea is that this lectin domain is larger in murine and bovine coronaviruses, and they're engaging a variety of lectins to bring this enzyme tightly up against sialic acid. Now that's gone, and there's a looser affinity for sialic.
That makes sense,
right?
Yeah, I wasn't totally sure about those specific binding details. As perhaps will surprise no one, the thing that I got really interested in was why it might be advantageous for these domains to be lost. And they speculate it's because of these domains being really good targets for antibodies. They are, they refer to them, an antigenic liability.
Yeah, I like that.
I like that too. Yes. And so in losing these domains, there potentially is some issue with binding, and they don't really discuss the details of that, but you get the benefit of avoiding antibodies. And so I think the idea of when a virus has to adapt to a new host like humans, that it's going to have to sort of make some of those trade-offs to deal with the human immune system versus infection is a really key point.
So they make this point that, you know, adaptation to the human respiratory tract led to this, right? And the assumption is that you don't need this lectin interaction there for some reason. Of course, we don't know the original host of this HKU1 or where in that animal it replicated, right? If it replicated outside the tract. Because if it were an intestinal virus and it found itself in the human respiratory tract, I could see that you don't need certain proteins. On the other hand, the human tract and the pig respiratory tract and a cow tract are all different enough that this could happen, I suppose. But this idea that
does this mean that the virus, I'm sorry, I interrupted somebody.
Go ahead.
Does this mean that the virus in humans reproduces at a lower particle number?
Yeah, we don't know.
Because it doesn't bind as well and it's slower in doing everything, and the KM might be different.
We don't know what the animal, we don't know what it did in the animal.
No, how do you know it was lost then? What it was lost from?
Well, because you have these animal coronas, the bovine and the mouse.
Comparing to the most closely related.
You know, if you look at the phylogenetic tree, these are the most closely related, and the presumption is they have a common ancestor. So yes, but we don't know.
And the most closely related that we're talking about are not other human coronaviruses.
No,
we're talking about the lineage in other animals that gave rise to this. So we don't know whether this was a pre-spillover event,
Right.
okay,
Yep.
or something that happened during the evolution of the viruses in humans, if that, in fact, if they actually have evolved in humans. We don't know quite when this happened.
The one thing that they do say is they talk a little bit about how these changes happened in both OC43 and HKU1. And so OC43 is the one that has been in humans for less time, if I'm remembering correctly. And it seems to have most of these changes be sort of smaller, more subtle mutations. There haven't been the same large scale deletions.
Yeah.
And so whereas HKU1 may have had time for it to have larger deletions. So they talk about this as convergent evolution. Two different paths of mutations happened. They resulted in the same final product or the same effect, but it's two different processes. And they talk a little bit about whether that is related to the amount of time these viruses have had in humans.
Right.
Convergent evolution is one of the coolest things going on.
Yes.
In fact, I don't know if we mentioned. I don't know if we mentioned this,
right,
but OC43, its structure was solved, and it was known to lack these decorations, right?
Right.
And so now HKU1 seems to have gotten to the same place by a different mechanism. I think it would be interesting to try and reconstruct this, right? We don't have the original host, but maybe you could put the loops back into HK1HE.
Yeah.
And then pass it in human cells, maybe human lung cells, and see if you lose them,
Right.
or if their presence is a detriment in some way.
Right.
That would be fun.
Well, if it's immune mediated selection, then the answer would be in cell culture. You wouldn't see that, would you?
No,
Right.
not in cell culture.
Right.
No, you'd have to have, but then you'd have to have an animal model, and it might not be
Exactly.
like humans. So it's hard.
And you're never going to get funded.
You won't get funded to do this. No,
I mean, who's going to fund a grant on coronavirus?
Coronaviruses.
Exactly. Exactly. Especially if they come from bats.
Yeah.
But then you may be thinking, what does this have to do with SARS-CoV-2? SARS-CoV-2 does not have an HE, right? It just has a spike. There's another envelope protein in there. But it could be that with time, SARS-CoV-2 is the most immediate spillover we have that's becoming a human virus. So with time, we may see things change in some way, but it will take time. I mean, here we're talking about 70 to 100 years and multiple centuries, right?
Yeah.
So right now people are saying the coronavirus is changing, but this is not the right time frame.
No.
It's going to be much longer, and maybe all of us are not even going to be around to see it.
No, your grandchildren might be able to study the changes in SARS-CoV-2.
So, Vincent, do you think? I'm sorry. Go ahead.
No, go ahead.
I was just going to say, when you look at the relationship between a host and its parasite, in this case, a virus, the less pathology, even though the growth rate may be slower, the longer lived the parasite is in the host. And you can come into a balance between, being totally eliminated by some virulence factor, like these loops, for instance. You lose the loops, you grow slower, but you can last longer.
Yeah. It's
so now you can have time to be transmitted to a lot of other hosts.
Yeah.
It has some selective advantage to be this way.
Yeah.
No,
so I think that's very interesting.
I mean, these coronaviruses are all in dynamic relationships, and when they change hosts, they undergo change. And this is an example of that, and that's why it's interesting. I wanted to just point out, I found an interesting review on some of these animal coronaviruses. And it says, many coronas have restricted host range, but some, such as bovine and SARS-CoV, seem to be more promiscuous. Some of these viruses that are similar to bovine coronas have been detected from respiratory samples of dogs with respiratory disease, from humans, and wild ruminants. For example, a human enteric coronavirus isolated from a child with diarrhea was very similar to bovine corona, suggesting it's a spillover. Right, and then they have some other examples of cross infection among different animals. So it's not just bats and humans.
For those of you listening while eating and hearing about a diarrhea and spillover in the same sentence, we apologize.
And an enteric bovine corona also infects dogs,
Right.
causes disease in birds, turkeys, chicks. So I just want to point out that the spillovers that we worry about are not just from bats, but all kinds of
Right.
animals with their own viruses can be an issue. And that's why we need to know what's out there and their
Yes.
potential to infect human cells. And as Rich said,
we've talked a lot about bats. I mean, not even just in this pandemic, but if you go back to older episodes, they come up a lot in this context. But there's any animal that has contact with humans could potentially have something that could spill over into humans, and we have these examples from cows and etc.
Bats are just cool.
Bats are just really cool,
and of course,
and they're very diverse and they're spread worldwide.
these viruses spread among non-human animals as well, right?
Yeah.
These took on them, and they can't do any research, so it's up to us.
No, that's right.
It's up to us.
I find the a virus that has this broad a tropism and pathogenesis all by itself interesting.
Yes.
Oh, absolutely.
To me, I think of viruses as having a narrower sort of, either being respiratory or gastric, but this is both. There's some adenoviruses that do that. I don't know too many other viruses.
West Nile isn't such a great. It's a good example of
okay.
a plethora of hosts.
Right. And one of the interesting things about viruses like that have this promiscuous host range is, if that's possible for some viruses, why don't all viruses have a promiscuous host range? I mean, there'd be huge advantages to it. And that type of what's required for the specialization, what are the advantages to the specialization versus what is the generalization getting versus the trade-offs that the virus has made evolutionarily.
Did you ask a why
Anything
question,
goes.
man?
I just did, yes. I asked a why.
When I hear why, I interpret it as what's the mechanism of, or
what's the mechanism?
What's the
Yes.
function of
Right.
having the
Right.
ability to infect so many different hosts? Yeah, because we can't
Sure.
answer why, right?
Right.
No.
All right. Before we do some email, I just want to remind everyone that we are getting summaries of the DAS coronavirus podcasts of Christian Drosten from IRENA. They're at microbe.tv/DAS-coronavirus. And we're up to the third episode so far since they resumed. Very nice.
Great.
Very nice summaries. Listen to this one. This is cool. So September 16th, episode 56, the main topic of conversation was the situation in Africa. No one knows for sure what's going on there. There are at least several papers that make us think they are approaching herd immunity, at least in clusters. However, it's impossible to make any robust conclusions as there are a lot of methodological flaws and lack of good data.
Yeah.
So you can, and then here's something that we talked about last time. At the end of the episode, Professor Drosten told a little bit about this letter to the New England Journal about masks having a potential for sort of variolation, which we talked about last week. He regarded this hypothesis as an interesting academic speculation, but noticed that it would be very hard to translate into any practical guidelines.
Yeah.
So that's where the variolation came from, the NEJM, huh?
Mm-hmm.
So anyway,
These are nice summaries.
it's very nice to see what's going on across the pond in DAS coronavirus. All right. Dixon, can you take that first email, please?
Leah writes, "Dear TWiV superstars, while I love hearing all the lovely haikus people submit, I think I'm better suited to contribute an irreverent limerick instead. So here you go. There once was an anti-masker who was also an anti-vaxxer. He got COVID-19. It was never more seen, and nobody missed the damn bastard. Believe it or not, I'm actually a compassionate person, and I certainly don't wish COVID-19 or any other disease on anyone, regardless of their personal persuasions. Nevertheless, in this crazy time, you've got to find a laugh where you can, right? Thanks for keeping me and so many others well-informed and amused. Stay grumpy. Lee from Oak Ridge."
I think that's really
Very
good. Isn't it
That
great?
It is.
That is good.
It is. It is. It is. We need more of that.
Dixon, you just talked. Rich,
I did.
Rich, can you take the next one?
Perry writes from Sheffield. Hi, TWiV team. Hello here from 17 degrees Sheffield in the UK. Very good news. In what I believe is possibly the first country leader announcement, UK Prime Minister Boris Johnson announced on live national press 9 September 2020, gives a YouTube link, UK strategy to have daily mass rapid testing, perhaps by saliva. Someone in the UK government is listening to Michael Minna. Admittedly, this is some months away. The technology is coming along, but not quite there yet. In the meantime, we are limiting gatherings to 6 people with some exemptions. Keep on TWiVing.
I tried to look at
Good.
this, but I couldn't get anything, and I don't know what they're looking for. I assume it's an antigen screen, but I couldn't read it.
I assume so.
I believe so.
But yeah, this says this live event has not yet started.
Oh,
That's what I get from YouTube.
Yeah, that's
Yeah.
what I got to. But it's over, so I guess they didn't
yeah.
record
So
it.
they live streamed it, but then the
didn't
archived
record it.
version must be someplace else.
All right. Alan, can you take the next one?
Sure. Martin writes, this may be of interest. I hold no brief for these companies and I know absolutely nothing about them, but 3 companies in Wallonia, the southern French-speaking part of Belgium, claim to have developed a new rapid test that may be of interest to you. It seems to test for past infections, so may not be relevant to the needs of the educational sector, but I don't feel qualified to judge that. And gives a link to this news source. Keep up the good work. Martin, who's in Brussels, and Unisensor, Chorus Bioconcept, and BioX Diagnostics. And I have not read this yet.
It's a serology test. Well, it's funny. They say there are 2 kinds of tests. There's tests for DNA and tests for antibody. And I'm thinking, what about the third kind for antigens?
Yeah, antigen.
They would lose points on my exam for that.
Yes.
So if it were a 10-point answer, how many points would you take off?
I don't know. It would depend on the question.
3.3?
I'd
Maybe
take off a
3.3.
third. I'd take off a
Point
third.
three.
Yeah, I don't know what this is, but it sounds like a rapid serological test.
Okay.
And in connection with this, Chuck Knersh sent me a link to an article about some 20-second screening test that's being done at Heathrow. Okay.
Yes,
And Dixon, you got this too, I think.
I did. Yes, I did.
It's an interesting. It is. They do some kind of screening, and they can detect the particles in some way. I don't know what this
Oh,
is.
yeah, I've heard
by
of
light
it.
scattering or something.
Yes.
It's
Yes.
a physical thing.
Yes.
In your breath.
Exactly.
Oh.
Wow.
Oh, is this like a mass spec type of?
Maybe
Something like that.
Maybe, yeah. It's hard to know. They don't
Huh.
tell. But the machine is about $20,000.
Right. Well worth it. If
I
it
don't think our
works that
school's going to
fast.
install one of these.
No.
But they've also tried. Heathrow's tried a lateral flow saliva testing strip as well, and they're going to share that. There's no detail here whatsoever. I don't know. I mean, you would think there would be technologies to detect the particles, but I would think there'd be a lot of background and
I would think so
Yeah.
too.
Yeah.
But
false
How are the
positives.
particles distinguished from other kinds of
From other
particles?
viral
Oh,
particles.
Yeah.
You've heard of Cryo-Em? This is Aero-Em.
Arrows.
No, I don't know. Anyway, thanks for
Who
sending.
knows?
I'm sure we'll see things developing rapidly over the next months. And Brienne, can you take the next one?
Sure. Rob writes, hello, people of TWiV. I am Rob from Maryland, and it's hot. I wanted to start with one of the more existential questions that has emerged to me during this pandemic. How do you keep your glasses from fogging up when wearing a mask?
Perhaps the most important question, right?
Yes.
Yes.
Exactly right.
I would link it to how do I keep my microscope from fogging up while wearing a mask? I started looking for answers regarding this in March, and I have tried all the crackpot suggestions: shaving cream, regular soap, dishwashing detergent. I have tried breathing sideways, breathing downward, putting the mask tightly around my nose and under the glasses. It's all BS. I have to take off my glasses every time I go inside somewhere. I am not blind or anything, but it is really annoying. Secondly, I was devastated when I got an email from JAMA saying that they were declining to include a comment I made on a paper they published a few days ago on their website. The paper is about vitamin D status and COVID-19 test results. Some of the issues I pointed out. COVID-19 is not tested for or transmitted. It is a disease caused by the virus. Good job, Rob.
Thank you.
Someone's
SARS-CoV-2,
listening.
which is tested for and is transmitted. How can a scientist mess this up in the title of the paper? That's a good question. There
Happens
have
all
been
the time.
tons of studies that have reached the conclusion that vitamin D may have some association with infection rate and or disease outcome, but not a single randomized controlled trial to prove anything. Why make a big deal about another study that suggests an association but proves nothing? The study uses previous vitamin D levels from sometime within the past year to determine the category the subjects should fall into: likely deficient, likely sufficient, or unknown. With that rock solid science, shouldn't they all be in the unknown category? Saying these findings appear to support a role of vitamin D status in COVID-19 risk seems like quite a stretch when you attempt to look at the actual study. They just assume that everyone acts the same in attempt to control for vitamin D level. Vitamin D was the only difference in these 489 people. There's no difference between Bob the biker that went to Sturgis and the RNC and a Labor Day party versus Vinny the rack and yeller that stays home. But what do I know? I am just a computer science graduate student. And as we all know, if your profession has the word science in it, you're no scientist. Anyway, I was just annoyed seeing people make a big deal about this as if we found a cure or something. Nothing against JAMA. They seem to be well organized and well managed. I am still uncertain as to why they declined to include my comment, though. Was it formatting? Could they highlight my work? Was it because I labeled my primary affiliation Common Sense and my primary source TWiV? Who knows? Love what you guys do. I randomly saw Vincent on a Twitch stream back around March talking about the virus. He sounded like he knew what he was talking about, so I searched around and eventually found TWiV. I have been listening ever since, and I'm very appreciative of you all and everyone you have on. Thanks, and stay safe.
I got to say, that's the best explanation of why these associations don't tell us anything, right?
Yeah, Rob,
Yeah.
you're right on the money.
Exactly.
Right on.
Absolutely.
Right on the money.
Exactly.
I don't
JAMA should
know.
have published your comment, although it may have been, they may have just decided that it was a little too sharp-edged.
Yeah.
A little too true.
A little too, yeah.
Yeah.
You needed to tone it down a little bit. I'm not
So I want to relate another mask problem for a subset of individuals out there, and that is those of us who wear hearing aids. As my hearing doctor put it, there's just not enough real estate back there on the back of your ears if you've got hearing aids and glasses and a mask.
I like that real estate. That's great.
Yeah. So I've gotten so that I just take off the damn hearing aids. The mask has priority.
That's a good
well,
point.
so much of what you hear out in the world anyway is just not.
Yeah,
worth
it's
it.
just,
So
yeah, exactly.
You're not missing much. Trust me. Yeah, the glasses problem. I generally wear glasses. I take them off for TWiV so I don't get glare from the lights. But
Good
but yeah,
solution.
this is an ongoing issue, and it's going to get worse in the winter. And if anybody's got ideas that work other than these silly anti-fog measures that, as we just heard, don't.
Actually, I haven't tried. I've got this stuff that I use on my swim goggles, or you can work on a diving mask that's
that
an
might work.
anti-fog stuff. That might work.
I'm not going to spit
could
on my
work.
glasses every time I got to put on the mask.
I just
That's what I
find
do
if
with my
you-
dive mask. It
I
works
find
great, but
if you put the mask under the glasses, that it helps. But
Under.
It goes away, doesn't it, with time when the temperature equilibrates?
I
Yes.
wind up taking my glasses
You do?
off. I do the same thing.
Yeah,
Rob
I-
does.
But your breath goes up underneath the mask and onto
Yeah.
your glasses
Yeah.
right away. So
I
that's
do find that if I make a point of exhaling through my mouth,
right.
it's less.
Mhm.
It doesn't stop it completely, but when I breathe out through my nose, the fog just goes right up the glasses.
Mhm.
When I breathe in through my nose and out through my mouth, it gets just a little corner. So that's
So
one
there's
of
an automotive product that you can use on your windshield also to prevent it from fogging up.
them.
You might want to try that.
It's funny. Daniel, in his previous report, pointed out a JAMA ophthalmology article, which is association of daily wear of eyeglasses with susceptibility to COVID-19. So there's a slightly reduced outcome in people with wearing glasses.
See, I shouldn't feel smug after all about not having to worry about this fog problem.
To which I say there's going to be a run on, fake glasses where it's just glass in there. Or goggles. You could wear goggles.
Swimming goggles. That's right.
Anyway, we published your article here on TWiV.
Yes, we published your comments here.
Okay.
If anybody from JAMA is listening, you should go ahead and publish.
Why don't you publish it, JAMA? Come on. It's probably because his affiliation was Common Sense. They probably thought he was too snarky. Right.
So that's what I'm saying. They thought it was too sarcastic.
All right. John writes, hello, TWiV band. Yep. We're a band. I would like to present my perspective on the vaccine debate from TWiV 660. First, the science on vaccine risk. Let's look at the science of the 1976 flu vaccine. The vaccination campaign of 45 million doses was associated with 450 cases of Guillain-Barré syndrome, resulting in 25 deaths. On average, 1 in every 100,000 patients experienced this complication, and less than 1 per million died. Complication of this magnitude is unfortunate, but since the vaccine benefit is usually estimated at 40,000 flu-averted deaths per year for a 60% coverage, the benefit exceeds the risk by more than 1,000 to 1. Moreover, it is unlikely any phase 3 trial of 30,000 subjects would identify a complication with a rate of 1 in 100,000, no matter how prolonged. Well, it depends. We saw a transverse myelitis in a trial of less than 30,000 people, and that's about 1 in 100,000, right? So it's just...
But we don't know that was vaccine associated.
No.
I think they concluded that it was not.
It was not.
It was not.
But I'm just saying...
Yeah, but it's...
random
Indeed,
things.
but it's too bad it stopped a whole study for a while,
The
right?
point is that if it's at 1 in 100,000, doesn't mean you're not going to see it in 30,000 people, right?
You might.
Right,
You might.
right.
A trial with clear early statistical evidence of efficacy is statistically unlikely to be negative in later stages. I would conclude 1, vaccines have been very safe, and the ratio of benefit to risk only increases with a more dangerous pathogen such as SARS-CoV-2. 2, adverse effects, particularly those with characteristic features such as Guillain-Barré, are easily identified and elicit disproportionate anxiety based more on fear of the unknown than on real danger. 3, with vaccines, like all preventative medicine, their benefit manifests by the absence of disease and invites the conclusion they were unneeded. That's right.
Yep.
4, public confidence is low in part by failure to communicate a consistent message regarding true vaccine value. 5, there is substantial anti-vax movement in our country. These are not evil people, but they are not likely to support any vaccine program, no matter how well performed. We should not make their conversion our goal. And 6, I'm a physician out there fighting the good fight, and I'm hoping the miasma of misinformation on SARS-CoV-2 vaccine does not prevent my timely vaccination. None of us wants to be a martyr to our unconscious biases. Well, I think those are all good points.
Yep.
Those are great.
Yeah.
And it does reiterate the point that we've made before that a good phase 3 trial is not going to reveal necessarily all the potential adverse effects.
Right.
A lot of these things are rare enough so they don't show up until the vaccine is deployed at large.
I think the key thing to remember about the 76 swine flu vaccine is the Guillain-Barré cases. Yes, they were rare, but they were more common than with other flu vaccines. So I think a big concern there was that this appeared to be less safe than it should be. It's not that it was unsafe or that the risk-benefit ratio was really became unfavorable. It was that something was wrong with this vaccine. And given the tenuous relationship that a lot of the public has with vaccines to begin with, I think that was the basis of the decision to just, pull that off and say, okay, we're not gonna keep distributing this because it's not up to snuff, basically.
Well, the problem is that there was never any swine flu outbreak, so there was no risk.
Right, exactly.
So this was the only risk.
Right.
Taking the vaccine was the only risk at the time.
Right.
Yep.
Was that what you're going to say, Rich?
Yep.
Oh, sorry.
It's okay. As long as it gets said.
Dixon, can you take the next one?
I can. Yvonne writes, and then she gives a link to a CDC site saying which flu vaccines are adjuvanted. So, hi, TWiV. Dense smoke in 78 degrees F, California. These, go to the links, are the adjuvanted flu vaccines licensed in the U.S. Thanks so much for TWiV. You want me to take the next one, too?
Let me just make a comment. You can take the next one.
Please do. Please do.
This goes back to our discussion on the memory of flu vaccination, which was a study using unadjuvanted flu vaccine, and the memory B cells are gone within a year, and we suggested that maybe adjuvanted vaccines would help, and they're not offered here, but they are offered here. So thank you for that. I thought they were only offered in Europe, but apparently you can get them here as well. Whether they will solve the problem or not, we don't know.
Yeah, there are certainly different adjuvants available in Europe than here.
Yep.
So yes, there are some adjuvanted vaccines available here, but there are other adjuvants that are not licensed here that are available in Europe.
Yep. All right, go ahead, Dixon.
Okay, Bob writes, wow, TWiV 660 gave me a pause a little late, as both my wife and I and two different neighbors are on the Moderna phase 3 trial. I think I got the placebo, but the second shot will tell the tale. Dr. Griffin has me worried now, but I knew the job was dangerous when I took it. I agree with all the comments you all made about how bad it was for the CDC to have tried to cover for Trump's magical thinking. But I think it could be bad no matter what happens. If he tries to push a vaccine early and the grown-ups resist, then the election happens and we hope Trump loses. Then in December, or worse, January, right after the inauguration, the data does show that the vaccine is okay. Is it going to look politically motivated in reverse, causing a whole section of the population to distrust the CDC and FDA even more, right when we were trying to convince them that they need to get vaccinated? I, for one, no longer want to live in interesting times. I love the podcast. Bob.
I think this is politics, and there's no way you can do it right.
No, there isn't. No, that's right.
That's right. It's absolutely
right. I think the best we can do is try to communicate what's actually happening with the story and talk about, well, we think that December, January is, sensible, and start talking about that now.
Yeah.
Sure. But what's interesting most about this is even if it's ready in, let's say, the middle of October, getting it to people, that'll take another 2 or 3 months. So having the vaccine in hand is not the same as getting the vaccine, right? Maybe June before I get
also, I think it's very important to remember that no matter when the vaccine comes out, it's not Trump who produced it.
That is all.
And it's not, in fact, it's not any of the politicians on your ballot from the presidential candidates down to dog catcher or whatever you're voting for in your locality. None of them had anything to do with producing this vaccine.
Right. And so
if it comes out before the election, don't go into the voting booth and say, oh, I'm voting for the incumbent because they produced it. No, they didn't.
No, none of them held a pipette.
None of them held the pipette.
I'm doing a write-in for Tony Fauci.
This is being done by private corporations with substantial government support. And yeah, you can credit the politicians who supported public funding for this, but don't decide your vote based on whether or not the vaccine has come out.
Not at all.
I think, Alan, the people who need to hear that are not listening.
No, they're not listening.
This is all true.
Exactly. Yeah.
Yeah, I think to a large extent we're preaching to the choir. But what
maybe we should hire a skywriter.
No, I think the people who would need to hear that aren't going to make the decision on that basis anyway.
No. Rich, can you take the next one?
Mark writes, Dear Twivers, despite Vincent's best attempts to alienate me in previous grumpy emails, he called me mean. I still enjoy TWiV greatly. It helps that I found a Chrome extension that translates grumpy to tolerable. That's great. Only affects Vincent, strangely. I'm a medical practitioner of 37 years experience in Australia. It's 18C and sunny today in Sydney with a high chance of brush fires through the summer. The attached PDF of Australia's premier newspaper to doctors, Australian Doctor, will probably interest you. It is distributed free only to Australia's 50,000 registered medicos which is why I had to create a PDF for you to access. And Australian gastroenterologist Tom Barodi claims to have developed a triple therapy to effectively cure, in quotes, COVID-19. Ivermectin, doxycycline, and zinc picolinate. I'm just...
Can I roll my eyes at Rich? Is it okay?
I know. You can roll your eyes. I'm trying to sort of manage what's going on endocrinologically inside me. I await... I await details of his regimen, access to which requires that I phone a pharmacy in his suburb near his Center for Digestive Diseases.
God.
He gives a link. Before you laugh and discard it,
Too late.
I do note that Barodi is the doctor who invented triple therapy for gastric ulcers. Helicobacter research in Australia was new at the time and pioneered fecal matter transfer, FMT, for C. difficile worldwide. Those are two notable accomplishments. So he's no dummy.
Does he have Nobel Prize? Because the people that did that in Australia have a Nobel Prize.
This is somebody else.
That's what I thought.
He has met with 2 U.S. presidents, a feat which has been radically devalued in the past 4 years, and lectures in the U.S. I'm unsure of the provenance of his professional title. I listened to your TWiV with your expert on ivermectin. I forget her name. She was TWiverific. And it seemed to be a drug effective only at concentrations unachievable in real life, orders of magnitude higher than the FDA-approved dose. I'd appreciate your thoughts on claims and whether publishing this to a wider medical profession is sensible or potentially dangerous. Cheers, and continue in appropriate grumpiness to set the SARS-CoV-2 agenda. Mark.
Okay, so just a quick note about pointing to somebody's past accomplishments to judge their current claims. Linus Pauling won 2 independent Nobel Prizes,
That's right.
and he thought DNA was triple-stranded and vitamin C could cure cancer.
Yes.
There is a long history of people accomplishing extraordinary things early in their career and then going absolutely bats crazy later in their years.
Right.
Or just coming out with weird ideas that don't necessarily make sense.
Yep.
And
like Watson, for instance, the original DNA man.
If you go back, Jim Watson was always problematic.
Mm-hmm.
But yeah, he's become more quotable lately.
Yeah, I think that's important to point out, that just because of someone's credentials doesn't mean what they're saying right now is necessarily right. Yeah.
Yeah.
Is this one of the Nobel Prize winners though?
No.
From Australia?
No, this Barodi does not sound familiar.
It was another name. What was his name? He actually drank Helicobacter himself, right?
Yeah.
Uh-huh.
I mean, let me look it up.
Yeah, I'm doing that right now.
So somebody give me the dope on ivermectin.
So that was Doris Cully, my wife, who was
Barry Marshall and Robin Warren.
Barry Marshall, right?
Right.
So Doris Cully, my wife, was on that episode. She worked for many years at Merck on ivermectin, and her point was that it's only licensed to be given every 2 weeks for scabies at the most, and the other doses are much less. And her point was you couldn't give people enough to reach the doses that you needed that they saw in cell culture. Now, I have 2 comments. First, he says he claims to have developed a cure. Well, if you don't do a randomly controlled trial, double-blinded, you can't develop a cure. I mean, if he's fooling around with his little practice, that's one thing, but it doesn't mean anything. And so he does actually have on clinicaltrials.gov a trial for ivermectin, zinc, doxycycline, vitamins D3, and vitamin C, all together to be tested in a randomized clinical trial in Arizona. I don't know how you're going to figure out which of those does anything. I mean, you can't give enough ivermectin in this trial to test efficacy. So he's hoping that the other things will. I just don't see where the basis for this is at all.
I was just thinking that if the trial fails, you can't even conclude that none of them do anything.
Right.
Right.
However, if the trial works, none of these seem like particularly expensive drugs, and you could potentially save lives. So if there's any basis for doing it, and I mean, if they got the IRB to approve it, then fine, go ahead and do your clinical trial, but don't call it a cure until you have your clinical trial published.
Right.
Right. It's great to publish these claims if you have data behind them. At that point, it's sensible, but without the data, it is potentially dangerous or just not useful.
And I've got to say, it's real fishy that you've got to call this one pharmacy closely associated with this one doctor to get access. That looks bad.
Yeah.
So
but if you have now, you can have two of them.
Yes.
Operators
are standing by.
I showed this to Doris, and she said, look, if they convince the FDA to do a trial, they have something, so we'll see. Fine. Yeah. I'm a little suspicious because ivermectin on its own doesn't seem to be enough. No.
But the important thing is, you got to do the trial.
Okay, so what she did say is that with increased dosing, ivermectin does accumulate in tissues, right? There's a name for that. What is it called? Target level or something, and it stays around. And so it could be that after so many weeks of dosing, you have enough, even though it's above the approved, to do something for the virus. So we'll see. Alan, you're next.
Okay, Tim writes, hey, TWiV team, I have the opportunity to sign up for a COVID-19 vaccine trial that's starting soon in Germany. I don't have all the information about it yet, but I'm excited to hear the upcoming episode about it. I like listening to the podcast because you get to hear some positive news about it all rather than all the negative stuff on the news. I was wondering what happens if you're in a trial and a successful vaccine is released. As a healthy 20-something, I don't feel as at risk as others might, and I realize I wouldn't get the vaccine first anyway. But if the trial is 12 to 14 months long, does this mean you could end up with a placebo or ineffective dose and not be allowed to get a proven vaccine because you're participating in a trial? Maybe this is too optimistic in terms of perspective on a vaccine being released. I look forward to hearing the episode and see what else I should be considering. Real good point, Tim. That's
well, you can pull out of the trial anytime you want.
You can bail out of the trial. And as I said on the last episode, most of these trials are being set up for 2-year follow-up so that they can follow people for any kind of complications. Efficacy, they should get an answer within a couple of months. So that's, you wait for people to get infected and see differences between your placebo and control groups. If you're participating in a trial and the trial discovers it's efficacious or discovers it's not, but some other vaccine comes out and it's 6 months from now and there's wide availability of an effective vaccine, you can bail on the trial and go get the effective vaccine would be what I would do.
When you sign
in fact, it's entirely feasible that for ethical reasons, the trial that you're in would tell you to do that.
Yeah. And when you sign the agreement, it says, if for any reason you want to quit, you can do it. They have to put that in. So you could always do that for sure.
This is definitely an interesting question, though. It's not really something I've thought about before. And I wonder how frequently in the past has this been an issue where there have been competing vaccines sort of all at the same time.
I can't think of an example.
Not at the same time.
What about the polio vaccine, Vincent?
Well,
those were sequential, right?
Yeah, the Salk vaccine was trialed in 1955, licensed and used. And then the Sabins were licensed in 1961. So they were trialed elsewhere afterwards. So, there are certainly multiple vaccines for a couple of diseases, but I don't remember them being trialed at the same time. This is unprecedented for sure.
Yeah.
I would agree.
Sorry to use the word unpressidented, but yeah.
Do we use that a lot? Yeah.
Oh, gosh. Everything's unprecedented these days. That's but
I'll put it another way. It's something new.
It is. Yeah.
Yes.
Yeah.
Brienne.
Sam writes, hi, TWiV team. Wanted to say thanks for supplying the general public with a good analysis of publications coming from researchers in the realm of virology. It's not always perfect, but 99% is spot on. I've come to trust the analysis from your team, which is big because I've been a big skeptic since I was age 13. When the FDA ran its first series of closed-door sessions that led to the reclassification of OxyContin that led to the opioid crisis, I stopped trusting the government at face value. This led me on the journey set off by one of the best pieces of advice my father gave me. If you want to master a subject, you have to read all the footnotes. That's good. Since that time, I've always delved into the source material of any news article science. Purely on semantics, I've seen time and time again journalists twisting words or just plain outright misunderstanding the research printed in a science publication. Although I'm still a novice with only 1,000 or so readings under my belt over the past 2 decades, I always wished there was an outlet that would quickly summarize the publications I'd come across, especially ones I could trust as unbiased, or at least one I could trust with a non-facetious bias. You are that dream come true. Thanks for all that you do. A fan, Sam. P.S. Been a fan BMM before Michael Mina. Please don't let the new celebrity grow any big heads.
I think
That's
it's
great.
interesting
Thanks,
that
Sam.
he pinpoints the age of 13 as becoming a skeptic, right? It's very precise.
I wouldn't necessarily put us in the category of quickly summarize.
Yeah.
No, we're not celebrities either. I mean, in the scheme of the world, this is nothing. But you guys like it. That's all that matters, right?
Yeah.
It matters that the people who are listening enjoy and learn. Vincent, okay. Richard writes, Dear Team TWiV, today, Labor Day, TWiV showed up on my Google News feed. Could be AI, but I think that it's that you guys are great. Keep up being the most reliable source on virology in general and things COVID in particular. Please pass it along that I've been using the other Racanellism, that's excessive, relating to some of the protective protocols for COVID transmission and the heat in Southern California. 121 Fahrenheit in the San Fernando Valley yesterday. Wow.
Wow.
Richard
That's
DDS.
hot.
Do I say that's excessive? Do we say that's excessive?
Not excessively.
Not excessively.
No.
All right. Let's do another round.
Maybe we do. I don't know. Somebody should count up.
Dixon.
John writes, a sense of humor at NCBI, otherwise now on Earth or beyond. Did this wind up here? 3.2 detailed analysis of COVID-19 epidemic. We now analyze all reliable genetic, epidemiological, and geophysical and astrophysical data. This leads to the astrophysical data. This leads to the alternate hypothesis that COVID-19 arrived via a meteorite, a presumed relatively fragile and loose carbonaceous meteorite that struck northeast China on October 11, 2019. This is at odds with the mainstream expert infectious disease opinion of traditional person-to-person spread of an infectious epidemic disease such as, for example, cholera, Vibrio cholera. John, that should have gone in Mad Magazine.
It's actually a journal called Advances in Genetics, EPUB ahead of print. And Alan, do you know anything about this?
Okay, so the first thing to understand here is that NCBI
They have a sense of
National
humor.
Center for Biotechnology Information. That's the source of PubMed, and they are not curating anything. They are a database of journals, and there's a certain very, very minimal set of standards to declare yourself a journal. There are 1.8 gazillion, and that's an exact number, journals indexed on PubMed. A huge proportion of them are just somebody created a journal so that they and a couple of their friends could publish some papers. I mean, that happens. And that can be done, and it gets indexed in PubMed. So there's an enormous amount of crap in PubMed. Just because it shows up there does not make it real.
You know, I can't tell if these guys are being funny or not. That's the thing, or serious.
And they're serious. So
Serious.
if you look at the affiliations, they've rounded up a couple of doctors. There's somebody from University of Toronto Health Network and someone from clinical pathology. Pathologists are a little offbeat anyway. At a university.
Not usually that offbeat, Alan.
Pathologists will agree that every pathologist I've met, I've liked talking to. But
Yeah.
a lot of them have kind of an odd outlook. Anyway, most of the authors are from places like the Institute for the Study of Panspermia and Astroeconomics in Gifu, Japan. The Buckingham Center for Astrobiology at University of Buckingham. What else do we have here?
There are some cool people who do astrobiology.
Yes, I was going to say it's not. We won't poo-poo that whole thing.
My point here is that these are people who have a very specific interest.
Agenda. That's right.
In looking for life from outer space.
Yes.
And I don't know what astroeconomics is, but that
meteorites get a good price on the open
very
market.
Specific theory about things. So these folks, I think, are coming into this with the idea of constructing a theory that would give an astronomical origin to SARS-CoV-2. I don't see anyone on here who's an actual virologist.
No, you wouldn't.
And I haven't done a deep reading of this paper, but I just really think this is a big stretch.
Well,
I agree.
I
Sure.
find the final sentence somewhat confusing. This is at odds with the mainstream opinion of traditional person-to-person spread of an infectious disease. Does that mean that every single person with COVID-19 got hit by a meteorite? And there was no person-to-person spread?
And I'm not clear on what the sunspot cycle has to do with this.
Every 11 years.
Yeah. Oh no, I'm quite familiar with the sunspot cycle. I follow it rather closely because I'm in ham radio. And by the way, the cycle 24 has officially ended. We're in cycle 25 now. That was just made official last week. But yeah, there's a lot going on here that just is a kind of grab random pieces of information and try and force them all into our theory type of approach. And I think this is not intended as comedy.
Now, when I was a youth, which was quite a while ago, I was attracted to a certain book called The Black Cloud, and it was written by Fred Hoyle. And Fred Hoyle was the astronomer royal for London, for the world, basically, but essentially in England. And he was a bona fide astrophysicist, and his hypothesis of life was these large nebulae in outer space, which have all the chemicals inside, and all of a sudden you've got this black cloud of life. And if your planet has to drift through that black cloud, you could acquire some of that material. And people bought into that a lot and thought, if the astronomer royal says it, it must be true. But it was science fiction, for God's sakes. And that's the difference.
The other difference is that's a theory to try to explain something we don't understand.
Yeah, but
there aren't really great data on the origin of life because nobody was around.
You're right.
And so we've got these various experiments trying to replicate the early Earth, and you can get some of the building blocks. And there's a pretty sound, believable story about how life originated on Earth, but you could come up with others like this black cloud theory that are not impossible.
Or for comets from comets.
I mean, that's within the bounds of something that I would expect an astrophysicist to think about and come up with a theory of it. It's not really testable.
No, so here's a modern fast forward belief system that's carried from that kind of thinking into a society that has its own journal.
No, I think this is a bit more because here the astrobiologists are stepping into a situation where the virologists and the epidemiologists have figured out pretty closely what happened. I mean, it came from a bat. We've got it down that we know this thing. we've got a real close relative in bats. We've got a history of coronaviruses coming from bats. We've got everything lining up very nicely with this very straightforward explanation that doesn't invoke anything extraterrestrial.
Right.
And then trying to throw in some theory that has no backing whatsoever about a meteor bringing in this virus that is somehow nearly identical to one that was already found in bats. It's just really, really hard to buy it.
Well, I think the first sentence, Brienne was attracted to the last sentence. I was attracted to the first sentence. We now analyze all reliable genetic and astrophysical data. The unreliable data we'll leave to Fred Hoyle.
Wow, that took more than I thought it would. I just wanted to know if they were joking or not.
I don't
think they're joking, but I don't buy it.
No, we of course don't buy it. But if they buy it, that's kind of scary, right?
A little bit.
So I'm just reminding myself here of a paper by Francis Crick and Leslie Orgel. You know this one? That's titled Directed Panspermia. And this is a hypothesis that they published in Icarus. I'm not sure what that is. In 1973. I'm about
Sounds
to
Greek
look
to
this
me.
up. About the idea, oh my goodness, Icarus is an Elsevier journal. In 1973, about the possibility that life on Earth started because somebody deliberately shot DNA at us from outer space.
Right.
I read that sci-fi book.
You don't believe that, Rich?
No.
He said with an almost straight face. I mean, everybody's guess is good as long as we don't know.
That's right.
All right, let's
so
move
if we're
on.
talking about origin of life, I
move
think you can
That's a tough
speculate
one.
all you like. But
That's
if
a
we're
tough
talking about origin of a specific virus, that we already pretty much know the origin of.
Right.
Right,
Rich.
just it did remind me of that. And
Yes.
in particular, because those two guys, Crick and Orgel, are the authors of the paper. I always thought that was a little far out. Okay,
You're next, Rich.
I'm next. We've talked about that enough?
Yes.
Oh, absolutely.
Okay. Joseph writes, Dear TWiV, I'm an old immunoglobulin savvy researcher who has made many polyclonal antisera and used them to identify proteins in my research. I listened to all TWiV podcasts, and I have a question over a point that Christian Drosten made. He suggested that COVID-19 virus may be coated with immunoglobulin secretion in the nose and expel such preheated virus when they sneeze. In that case, it brings up for me the question of IgA, which I have heard nothing about in any past discussions by anyone. Is there any rationale by which IgA, in my ancient reading, were often associated with secretion from the eye, mouth, and nose, could be a strategic help in fighting COVID-19? Keep TWiVing, Joe. Okay, so Brienne, I'm going to turf this to you because I want to hear your spin on IgA and this letter.
Okay, so IgA is a type of antibody that's usually found, just as he said, in mucosal secretions like eyes, mouth, nose. That's where it's at the highest levels, GI tract, all that good stuff. Most of the studies that I think we have really been thinking about have looked at antibodies in the blood, which is not usually where we see a lot of IgA. So I agree with Joseph that I haven't seen a ton of studies about IgA levels in the nose and how that might influence, say, upper tract versus lower tract infection or things like that. I think that that's an open question. The big place where people are thinking about how this could be helpful in fighting COVID-19 is that some people are talking about making vaccines that are mucosal-based vaccines versus systemic. And the idea with perhaps a mucosal vaccine is you give the vaccine at one of those mucosal sites, and that makes the body more likely to make a mucosal response, which could include IgA. And that is often a good neutralizing antibody in these mucosal sites.
Would that ultimately result in a more broad immune response? So if you start off with IgA, do you wind up developing IgG and et cetera as well? Or is it restricted to IgA?
So you always start with IgM, and then the B cells get to switch, and they could switch either to G or A or E.
So in a mucosal vaccine, would you expect both or predominantly IgA? Are you going to get?
I think that you would expect more IgA than you would with a systemic vaccine.
Okay.
So when you put the immunogen intranasally, it will be taken up subepithelial antigen-presenting cells, and they'll make a mix of IgG and IgA, right?
Yes, exactly.
Okay.
And I think Merck at least is hoping that they can do that with the vaccines that they're developing, the attenuated vaccines.
We had, no, they're vectored, not attenuated. We clarified that.
Oh, right. Yes.
We had gone over a mucosal.
But they are replicating virus.
Yeah, they're replicating. We had gone over a mucosal administered virus a couple of weeks ago, which is
well, there's the adenovirus vaccine that's administered to the military. That's wild type adenovirus. It's ordinary respiratory infection, administered in an enteric coated capsule, so that it goes into your intestine, uncose, infects your intestinal mucosa. Now, I presume that's an IgA response. That, interestingly, this is going to be some sort of what do they call them, like GALT or something like that, some sort of communication between the intestinal mucosa and the respiratory mucosa, right?
Exactly.
You put an image in your gut, and then you're going to get mucosal IgA elsewhere, another mucosal surge, right?
Exactly. So the idea is that the immune cells are sort of trained that they're supposed to go back to mucosal sites after they've been first activated.
Right. This would also apply to flu mist, wouldn't it?
Potentially. Flu mist, because it's also attenuated and replicating, has a lot of ways it's different from the normal flu vaccine, but that is one of many differences.
That it's being delivered to a mucosal layer, and the oral polio vaccine, of course, being delivered to the goat.
But we did cover one that's sprayed intranasally. I can't remember which one it was.
And it wasn't flu mist.
No, it wasn't flu. It was
we
SARS-CoV-2.
did, I don't remember.
Yeah.
Okay.
But they're looking at it, Joe, and I love his little thing.
The little ASCII art and the signature is cute, yes.
Very cool. All right, that was Rich Allen Dove.
Okay, Sylvia writes, Dear TWiV team, as field service personnel for lab diagnostics companies such as Abbott and now Euroimmune, I've been following your terrific podcasts for quite a while, long before COVID-19. However, now I dare to make a comment regarding Christian Drosten's answer to your question, what does Germany do differently? Because he forgot, or took for granted, whichever it is, to mention a very important aspect. Although it is definitely not perfect at all, we do have a truly social healthcare system in which everybody can receive medical care if they wish to, even people who don't have money to pay into it at all. That overall makes a big difference from the U.S., the place where my husband, a parasitologist working for the state of Bavaria, and I so much love to travel to, but which scares us more each time, because the ever widening gap between poor and rich is so cruel, and so many people are poor, although they are working so hard. Of course, this is no direct influence on the pandemic, but as Corona does in so many ways, it reveals what has been bad already. Anyway, why can't one of these countless billionaires in the U.S. start off some true Obamacare, or at least found a company health insurance fund that would help everybody in your country? Warmest regards, and thank you so much for your unique podcasts. Sylvia, from a small village close to the Austrian border, which unfortunately was, and our country still is, one of the hottest hotspots in Germany. Our county still is one of the hottest hotspots in Germany, and whose beloved neighbor, 71, female, very small pension, could survive a heavy corona infection in March due to full access to medical care at no charge. Yes, that is a huge difference, and it is to our, I think, enduring national shame that we have still, as the richest country in the world, been incompetent to fix this.
I would say, though, that the economic imbalance here did influence the pandemic. But Sylvia says this has no direct influence on the pandemic. Yes, it does, of course.
Yes.
Yes, it certainly does.
But otherwise, it's very sad that we don't have this. And I mean, there are people who could take care of it for sure.
Yeah. Well, but they have made their wealth and are keeping it to themselves and using it for their own pet projects like building spaceships. And that's what's going to happen if you have a philanthropist-based system, because you've concentrated the power in the hands of a very tiny and more or less randomly determined group of people. Whereas if you had that money taxed and funding public efforts, you'd be able to fund a system like this. But there we are.
Yep.
Now we're getting political.
Brienne.
No, we're not. We're just describing a situation.
We're
Just the way it
describing the
is.
situation, and this is a topic that has been important in public health for decades and has just not been fixed. I mean, the one major effort to fix it is now in the process of being gutted, because it was implemented by a black president and we're racists. There, I said it.
I agree. Alan.
Yeah, no, that's all true.
So I often say in company, I think, healthcare in the U.S. should be free for everyone because health is a fundamental right. And then people say, wow, there are no such things as fundamental rights. Okay, fine.
Really?
But that's what people argue. There's no such thing as a fundamental right. We're just biology. There's just life forms, and we make our
How
own.
about food and water?
We make our own
But
fictions.
then you're rejecting the founding principles of the United States. If you
Yes,
say there's no such thing as
yeah.
a fundamental
Which
right.
some
There are
people say-
we hold these things to be self-evident.
No,
that there
I
are
agree with
inalienable
you.
rights.
But these people would argue that there are no such things. It's all fictions made by
Right.
other humans.
Those people are libertarians and could be safely ignored until they get elected.
Anyway, then they say, okay, let's say everybody gets free health care. What do you do
Right.
when people come in, immigrants, they're on vacation and they get sick? What do you do with that? Do you give them free health care? They don't like
yeah,
that.
you
They don't
betcha.
like that idea. And they say, oh, people will
Tom,
just
yeah,
fly in
because-
from everywhere and get free health care in the U.S.
Because
They're
the people you're
isolationists.
arguing with in that case were born into a life of unacknowledged privilege, and
That's right,
acknowledging
that's
it
right,
would
that's right.
would just destroy their entire worldview.
I had a couple of physicians who I used to know, but I terminated our friendship because I disagree with their philosophy. They pulled my daughter aside once and they said, your parents work so hard. Do you think it's fair that other people get free health care and they've worked so hard for theirs? I mean, it's just ridiculous philosophy, right?
Right.
Alan just left.
Sorry,
Brienne,
I had to log in a child's computer.
that's fine.
I
Brienne,
heard what you said.
Brienne, you're next.
Yes, Willie writes, "Dear communicators of science, true scientific method followers who talk and share info. I heard this on Rachel Maddow, MSNBC, last night, September 16th, 2020. 6 million dead in the USA from SARS-CoV-2 if the current do-nothing herd immunity is followed. Do these calculation estimates on death rates from COVID-19 include reinfections or just initial exposure? Thank you very much, everyone at TWiV TV, for all you do to share vital, life-saving scientific research news on the corona pandemic. Even though most of us may have a sixth grader's vocabulary, thanks for using and explaining proper terms. Willie in Dallas, Texas."
I don't know if you
I
guys
have
heard.
I have my own calculation.
Yeah, so this is
All right,
a
what's-
common, and I think it's all preliminary infections or primary, not reinfections, right? Because that
That was what I thought.
Yeah, but
But I don't
yeah.
come up with 6 million.
What do you
Okay?
get?
Depends on how you calculate it. Okay. The World Health Organization's best guess that seems to have some consensus on it around the infection fatality rate, not the case fatality rate.
Right.
The infection fatality rate is somewhere between 0.5 and 1%.
Right.
There are 330 million people in the United States.
Right.
If you need 80% herd immunity to 80% people seropositive, exposed, in order to get disease-based herd immunity, okay, then with an infection fatality rate of 0.5%, that's 1.3 million dead in the U.S. It's 30 million dead worldwide.
That's right.
If the infection fatality rate is 1%, you get 2.6 million. Okay.
Yeah.
So I don't get 6 million, but 1.3 million is too many.
I think 6 is
And
based
if-
on the
if-
CFR. Yeah.
And if immunity is not sterilizing, which we're kind of converging on the view that it may not be, that it may be protective and not prevent you from carrying the disease, then herd immunity is a myth. Not going to happen with this disease, with a vaccine or not. I mean,
herd immunity in general is not a myth. Herd immunity in this case,
in this case, it may just be off the table. It may just be not achievable. If that is the case, then we'd be looking at something. And if the 1% figure instead of the 0.5%, worst case, we'd be looking at like 3.5 million deaths, which is a huge number of people. That is, so the 6 million, I think what we're winding up to here is to say that 6 million dead is excessive and not probably a credible number, but 3 million dead or 1.5 million
Still
dead.
a horrible number.
I mean, if you're quibbling over how many million dead, something's gone horribly wrong and you need to back up.
Well, I mean, if you do all the things you're supposed to do, reduced capacity, masking, distancing, it won't get to that point. But people don't want to do that. The key here is the infection fatality rate is based on the actual number of infections. But we don't know that, so we have to extrapolate, whereas the CFR is based on confirmed infections, and it's too high, right? That's the whole point.
Vincent, I'm going to change the subject entirely to just ask everybody to look at Vincent for a moment and think of Vermeer.
You like the light?
You have wonderful lighting right now. It's absolutely fabulous.
So
you are a Dutch master's painting.
So at this
should
time,
get a photograph of that.
Well, I am video recording it.
Oh, good.
At this time of year now, late September now, the sun.
It's fantastic.
Because normally it's too high in the sky at this hour, but now it's tilting down in the sky. It's over the Hudson River. Well, actually, it's over.
You've got all those gorgeous orange and red and yellows.
Rack and yellow. Rack and yellow.
Yes,
rack and yellow. That's right.
Those are rack and yellows. So a lot of people sent in this because they heard Rachel talk about this, but this is too much.
But the actual number would still be too much.
Too much. Of course, it's already too much. So, by the way,
her point carries that this approach is insane.
No, it's unacceptable. By the way, herd immunity, as we've said, it depends what you're talking about. If you think it will prevent infection, it won't, but it will prevent disease. Once everyone's been infected, you will get infected, you will transmit, but you won't get sick. That's the common cold coronas, unless you're frail. That was the word they used.
Yes.
Right?
Right. Whereas the herd immunity concept requires sterilizing immunity, because if you can have people be carriers, then you can't get to protect the people who are uninfected.
Right.
Okay.
I just suddenly was worried, Alan, that you were going to be a meme in an anti-vax thing or something.
No. Herd immunity is not a. So there are many vaccines for which we know herd immunity works very effectively. In fact, measles, polio, lots of serious diseases where if you get a large enough percentage of the population vaccinated, the virus can't gain a foothold because the vaccine provides sterilizing immunity. That is the key.
So I think of it, I try to describe it as population-based immune-mediated disease resistance. Okay. And we need a good acronym for this.
Population
to replace
based
herd immunity.
PBIMDV.
It's not got enough vowels.
Yeah. Okay. Hey,
We'll figure out
COVID-19.
something.
COVID-19.
COVID.
All right, last one is from Ruth. Hello, TWivers. One item discussed was that a person should receive the vaccine against SARS-CoV-2 with all doses of the series being the same product and how that should be tracked. Having worked for over 20 years in pediatrics, I am familiar with my state's vaccine database. I believe that most states have a similar system, so we already have something in place to track which vaccine a person was given. We had the same issue when the first HPV vaccines became available from 2 different manufacturers, with the recommendation that you complete the series with the same product for all doses. Perhaps this has already been brought to your attention by another faithful listener. Thanks for your informative and entertaining podcasts. So I didn't know that, but it makes perfect sense, right?
I did know that, but I want to highlight 3 particular words here: pediatrics and most states. So yes, kids' vaccines are tracked better than adult vaccines by far. Most states in the US have some kind of a system like this. They're not necessarily linked. So there is an issue when people move from place to place and their kids, they got these vaccines when they were in Michigan and now they're in Texas. But that information is usually transferred over. The problem really comes up with adults. Who got a flu shot this year and which shot did they get? And there we've got this real patchwork situation and not a whole lot of tracking going on. And that's the topic that I was referring to in terms of vaccine registries. We don't have, as far as I know, we do not yet have a really solid national registry system for vaccines in the whole population, which is what we would need for a SARS-CoV-2 vaccine.
And you don't think we'll have one? Oh,
gosh, no. No, that's not getting done.
All right.
Not anytime soon.
On that uplifting note.
Yes.
It's TWiV 665, microbe.tv/TWiV for the show notes. Questions and comments, go to TWiV at microbe.tv. If you'd like to make a contribution, you can go to microbe.tv/contribute. Rich Condit is an emeritus professor at the University of Florida, Gainesville, currently residing in Austin, Texas. Thank you, Rich.
My pleasure. Always a good time.
Brienne Barker's over at Drew University, and on Twitter, it is BioProf Barker. Thanks, Brienne.
Thanks. It was great to be here.
Dixon Despommier is at trichinella.org and thelivingriver.com. Thanks, you, Dixon.
It was a pleasure. Thank you.
Going fishing this week?
We got the young one over here now, so the answer is maybe, because he loves to go fishing.
Cool. Very good. Alan Dove's at turbidplaque.com on Twitter. He's Alan Dove. Thanks, Alan.
Thanks. It's always a pleasure. And I'm also on alandove.com. I'm giving that site out again.
Yeah, it says so right here in my show notes.
Yes, I did some renovations on that site. So now it actually lands on a basic introduction page. And
okay.
People can go from there.
I always liked Turbid Plaque.
Turbid Plaque is still, if you click on Science Blog, you get right to Turbid Plaque, and I'm still blogging.
Go to alandove.com and Alan Dove on Twitter. I'm Vincent Racaniello. You can find me at virology.blog. I'd like to thank the American Society for Virology and the American Society for Microbiology for their support of TWiV, and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Vincent Racaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.